Welcome to your Q&A session for the WGU Community Health and Population Focused Nursing exam. We'll tackle practice questions one by one, why the right answer works, why the others don't, and the concept behind each item. This video covers Module 1, Foundations of Community and Public Health Nursing, community-based, community-oriented, and population-focused nursing, what public health is and its mission, the 10 core services of public health, health determinants and social factors, goals and methods of public health nursing. Quick reminder, our website offers free study guides and practice questions designed to help you pass your D450 exam without all the stress. Just click the link in the description below to check them out. And remember, studying smarter always beats studying harder, so take advantage of these free resources today. Alright, let's dive in. Question 1. A nurse employed by a county health agency spends Tuesday morning at the home of a woman with heart failure, weighing her, reviewing her diuretic schedule, and reinforcing the low-sodium diet written into her individual care plan. Which practice area does this specific activity represent? Your options are A. Population-focused nursing, because the encounter happens outside an acute care hospital. B. Community-oriented nursing, because the nurse is employed by a county health agency. C. Community-based nursing, because the client is one individual receiving illness care. D. Population-focused nursing, because chronic disease management always addresses a determinant of health. Which one is it? Pause the video if you need more time. The correct answer is C. Community-based nursing, because the client is one individual receiving illness care. C is correct because community-based nursing is direct acute and chronic illness care delivered to individuals and families in settings outside the hospital. Everything in this scenario points to one named patient with a diagnosis and a personal care plan. The bedside relationship has simply moved to a new address. A is wrong because location is the most common trap in this content area. A home visit does happen outside the hospital, but the client is still one individual with an illness, which makes the practice community-based rather than population-focused. B is wrong because employer does not determine practice area. A county health agency nurse can practice all three modes in a single week, and this particular activity has an individual as its client. D is wrong because managing an established illness in one person addresses that person's disease, not the upstream conditions that produce heart failure across a population. Determinant level work would target income, housing, food access, or care access for a whole group. A nurse checks a weight, presses on swollen ankles, reviews a diuretic schedule, and reinforces a low sodium plan. Nothing about that hour looks like public health because it isn't. It's ordinary nursing care, just delivered at someone's kitchen table instead of a hospital bed. Community-based nursing provides acute and chronic illness care outside the hospital, but its defining feature never changes. There's a named person, a diagnosis, a care plan, and interventions aimed squarely at that person's illness. This category exists because of structural change. Hospital stays shortened, technology became portable, and chronic disease overtook infectious disease as the leading killer. So payers pushed treatment out of the most expensive building in the system. Somebody had to follow the patient out the door. The cleanest test is simple. Who is the client? If you could picture a chart with one person's name on it, that's community-based. If the aim is a neighborhood, school, or workplace, that's community-oriented. If a population was identified through health data, that's population-focused. Address is never the evidence. Don't mistake a narrow lens for an easy one. Managing a complex heart failure patient alone in a walk-up apartment, with no monitor and no backup, demands more independent judgment than most inpatient assignments ever will. Question 2. A school nurse notices that absenteeism climbs sharply every February at her elementary school. She launches a hand hygiene campaign with classroom demonstrations, hallway sanitizer stations, and a poster contest, with the stated goal of protecting the health of the school as a whole. Which practice area best describes this work? Your options are A. Community-oriented nursing, B. Community-based nursing, C. Population-focused nursing, D. Community health nursing in its narrow, individual-focused sense. Take a second. Which answer would you pick? The correct answer is A. Community-oriented nursing. A is correct because community-oriented nursing reaches individuals and groups, but the reason for the encounter is the health of a whole definable community. The school is that community, and the campaign is built to preserve and protect its collective health, rather than to treat any one student. B is wrong because community-based nursing would look like the same nurse treating one child's asthma exacerbation or managing one student's insulin supplies. No individual diagnosis or care plan appears here. C is wrong because population-focused practice begins with population-level health status data and addresses the broad determinants of health across an entire population. This campaign is anchored to one building and was prompted by an attendance pattern, not by a determinant-level analysis. D is wrong because the narrow, individual-focused reading of community health nursing describes hands-on care of specific patients in community settings. A school-wide campaign is the opposite of that. Community-oriented nursing still involves shots, blood pressure checks, and one-on-one teaching. But the reason those encounters happen shifts to something bigger: the health of the whole community. Picture two nurses giving the same flu shot. One reviews a single patient's chart during a routine visit, protecting that patient. The other closes a parking lot, recruits volunteers, and vaccinates 400 neighbors, protecting the community's collective immunity. In community-oriented practice, success isn't one patient's outcome. It's coverage and access across a definable group like a school or town. That scope is broader than treating one patient at a time, but still narrower than chasing a population scattered across a whole state. And critically, purpose decides the classification, not how many people are in the room. Consider a school nurse who notices absences spiking every February. Instead of treating each sick child individually, she installs sanitizer stations, teaches hand washing in every classroom, runs a poster contest, and partners with custodians. The client became the entire school. Community-oriented nursing is not a vague middle ground. It's where most public health nursing actually happens. And don't confuse it with health promotion. One names who the client is, the other names what the nurse does. Question 3. A public health team reviews 3 years of county immunization records and finds that childhood vaccination coverage runs far lower in neighborhoods where median household income sits in the bottom quartile. The team designs a county-wide initiative combining evening clinic hours, mobile vaccination units, and partnerships with subsidized housing managers. Which practice area does this initiative represent? Your options are A. Community-based nursing, B. Community-oriented nursing, C. Community health nursing, D. Population-focused nursing. Before I reveal it, which one do you think is right? The correct answer is D. Population-focused nursing. D is correct because population-focused practice identifies a problem through population-level health status assessment, traces it to determinants of health, and intervenes to reach the entire affected population. Data revealed the coverage gap. Income was identified as the underlying determinant, and the response reshapes access countywide. A is wrong because community-based nursing treats named individuals for acute or chronic illness. No individual patient appears anywhere in this scenario. B is wrong because a community-oriented effort stays anchored to one definable place, such as a single neighborhood, school, or work site. This initiative spans a county and targets a group defined by income rather than by locale. C is wrong because community health nursing is a broad umbrella label rather than a precise practice area, and it can describe individual-focused work as easily as population work. When a scenario supplies data-driven population targeting, the specific label is population-focused nursing. A clinic can only treat the people who walk through its door, never the ones who can't get there, don't know they're sick, or don't trust the system. Population-focused nursing exists to reach exactly those people, starting somewhere other than the waiting room. The definition packs in 4 separate commitments: targeting an entire population, identifying problems through population-level assessment, considering the broad determinants of health, and working across all 3 levels of prevention. Each one can be tested on its own. The sequence gives the practice its shape. Data come first. A pattern like hip fractures clustering in certain neighborhoods is found before anyone presents as a patient, then traced to the determinants producing it, and only then does an intervention get designed. Consider childhood obesity clustering in 3 neighborhoods. A community-based response counsels each overweight child. A community-oriented response builds a school lunch program. A population-focused response changes school meal policy, park funding, and zoning, and never meets most of the children it helps. Reaching millions isn't enough if it wasn't built from population data acting on a determinant, and a single program can qualify if it was. This is the philosophical center of the specialty. A well-designed policy can prevent more disease than a career of individual care. Question 4. 2 nurses disagree about how to label their work. One argues that any nursing care delivered outside a hospital building qualifies as population-focused practice. What is the most accurate correction to that reasoning? Your options are: A. Practice area is set by which level of prevention the nurse uses, not by the setting. B. Practice area is set by who the client is, an individual, a community, or a population, not by the setting. C. Practice area is set by whether the nurse holds graduate preparation in public health nursing. D. Practice area is set by whether the employing organization is a government health department. What's your answer? Commit to one before I continue. The correct answer is B. Practice area is set by who the client is, an individual, a community, or a population, not by the setting. B is correct because the width of the lens decides the label, and the width of the lens is revealed by the client. One person points to community-based practice. A definable community points to community-oriented practice, and a population identified through data points to population-focused practice. Asking who the client is resolves most classification items. A is wrong because level of prevention correlates loosely with practice area but does not define it. A population-focused program can operate at all 3 levels of prevention at once, and community-based care can include primary prevention such as one patient's vaccination. C is wrong because educational preparation distinguishes generalists from specialist public health nurses. It does not change whether a given activity has an individual, a community, or a population as its client. D is wrong because the employer is irrelevant to the classification. A single public health nurse can practice all 3 modes within 1 week while working for the same health department. The biggest trap in classifying practice areas is using geography as the rule. It feels intuitive, but it fails constantly in both directions. The correct rule is short. Practice area is determined by who the client is for that specific activity. One individual or family points to community-based nursing. A definable community points to community-oriented nursing. A population identified through health data points to population-focused nursing. Watch how the plausible substitutes collapse. Setting fails since a home visit is individual care while desk analysis is population work. Employer fails, since one nurse can practice all three modes in a week. Credentials fail, since they describe preparation, not the activity. And group size fails, since teaching many people one at a time is still individual level care. A single public health nurse might give wound care to a homebound elder on Monday, run an immunization clinic on Wednesday, and analyze county data on Friday. 3 practice areas, 1 nurse, 1 week, 1 job description. Keep this separate from level of prevention too, since they're independent axes. But the core habit to build is always asking, for this specific action, whose health am I accountable to? Question 5. The course uses the Head Start program as its canonical illustration of population-focused practice. Which feature of Head Start earns it that status? Your options are a problem visible in population-level data was traced to social and economic determinants and addressed for the entire affected group. B. It delivered direct clinical services to individual children who presented with documented developmental delay. C. It was designed and administered by nurses rather than by educators and social service staff. D. It concentrated its resources inside a single neighborhood whose residents knew and interacted with one another. Pick one, trust your gut, here's your chance to test yourself. The correct answer is A. A problem visible in population-level data was traced to social and economic determinants and addressed for the entire affected group. A is correct because no individual child walked in requesting Head Start. School readiness deficits appeared across an entire population of low-income children. The cause was traced to social and economic determinants, and the program was built to reach that whole population. That sequence, from data to determinant to population-wide intervention, is what defines population-focused practice. B is wrong because treating individuals who present with a documented problem is the logic of community-based nursing. Head Start was built for a population identified in advance, not for clients who sort it out. C is wrong because program staffing has nothing to do with the classification. What matters is that the client was a population and the intervention addressed a determinant. D is wrong because concentration in one interacting neighborhood would describe a community, and work aimed at it would be community-oriented. Head Start targeted a dispersed population sharing a characteristic which is low family income. Head Start became the textbook example of population-focused practice, not because of who ran it, but because of the logic behind it, understanding that logic reveals why acting upstream beats acting downstream. The sequence runs in a specific order. A problem shows up in population-level data, not in a single patient. The cause gets traced to social and economic determinants, not a pathogen or individual failing. Then the intervention reaches the entire affected population, not just those who ask for help. School readiness gaps aren't a disease. They're the downstream result of income, education, food security, housing, and preventive care access. Treating the readiness gap alone means endless remediation, but changing the determinants means the next cohort arrives already better prepared. The same pattern shows up elsewhere. Folic acid fortification lowered neural tube defects across every pregnancy in a jurisdiction. Water fluoridation cut dental caries across whole municipal populations. County-wide fall prevention reaches every older adult, not just those who mention a fall to a clinician. Population-focused practice means believing a problem is real before anyone files a complaint, and acting on a cause several steps removed from the visible harm. The credit is diffuse and the results arrive years later, but that's exactly the work that changes population health most. Question 6. A nurse newly hired at a state health department is asked to state the mission of public health as the Institute of Medicine framed it in its 1988 report on the future of public health. Which statement matches that framing? Your options are A. Delivering the highest attainable standard of medical treatment to every citizen who seeks care. B. Lowering national healthcare spending by moving services out of hospitals and into community settings. C. Diagnosing and curing communicable disease before it can spread beyond the initial host. D. Fulfilling society's interest in assuring the conditions in which people can be healthy. Which would you go with? Lock it in before the reveal. The correct answer is D. Fulfilling society's interest in assuring the conditions in which people can be healthy. D is correct because the Institute of Medicine defined the mission as the fulfillment of society's interest in assuring the conditions in which people can be healthy. The wording matters because it centers conditions and populations rather than cures and patients. Clean water, safe food, immunization, safe housing, and access to care are all conditions in that sense. A is wrong because maximizing treatment for individuals who seek care describes the aim of clinical medicine. Public health acts before people become patients and is accountable to people who never seek care at all. B is wrong because cost containment and shifts in site of care are policy goals. Public health may support, but they are not its mission. Successful prevention can actually raise lifetime health spending because populations live longer. C is wrong because communicable disease control is one important activity within public health, not its mission statement. The mission covers chronic disease, injury, environmental hazards, and the social conditions behind all of them. In 1988, the Institute of Medicine wrote the single most important sentence in this field. The mission of public health is the fulfillment of society's interest in assuring the conditions in which people can be healthy. The mission is not treating the sick or curing disease. It's establishing conditions where health becomes the default: safe water, safe food, safe housing, and enough immunization coverage that even the unvaccinated are protected. Society's interest means responsibility is collective, not individual. This is where the mission connects to social justice, treating health as a shared societal responsibility rather than something purchased privately. Consider a health officer facing a cluster of childhood lead poisoning. She can treat the affected children with chelation therapy. Or she can find the housing stock causing the exposure and force abatement, so the next generation is never poisoned. Public health does the first when it must, but exists for the second. People can be healthy is conditional, not guaranteed, because outcomes also depend on biology, behavior, and chance. That's why the field measures success in population rates, and why this mission statement, distinct from the classic 1920 definition, tells us what public health is for. Question 7. A program planner at a local health department is building the evidence base for a new initiative. She pulls disease rate patterns from surveillance files, runs statistical comparisons between two counties, surveys residents about health beliefs, interviews community elders about traditional healing practices, and arranges testing of private well water. Which description best characterizes what she is assembling? Your options are A clinical epidemiology workup which sits outside the sciences of public health. B, the assessment sciences that together make public health a scientific discipline. C, a completed assurance function, since she has verified that services are available. D, a tertiary prevention needs analysis for a population that already has established disease. Don't overthink it. Which one feels right? The correct answer is B, the assessment sciences that together make public health a scientific discipline. B is correct because public health is defined as a scientific discipline drawing on epidemiology, statistics, and behavioral, cultural, and environmental assessment. Her 5 activities map one-to-one onto those 5 ingredients. Those front-end sciences exist to feed the 2 products public health generates: which are policy development and program planning. A is wrong because epidemiology is not outside public health. It is described as the basic science of public health. The distribution and determinants of health-related events in populations is precisely what epidemiology studies. C is wrong because assurance means making certain essential services actually reach the population through direct provision, mandate, or linkage. Nothing here provides or guarantees a service. This is all data gathering. D is wrong because nothing in the scenario indicates the population has established disease, and no rehabilitation or complication prevention appears. Assessment precedes any decision about which level of prevention fits. Public health sounds like an attitude, a general commitment to helping people be well. But that impression collapses on contact with the actual work, which runs on measurement and evidence. Public health is defined as a scientific discipline drawing on epidemiology, statistics, behavioral science, cultural assessment, and environmental assessment. 5 sciences feed 2 products: policy development and program planning. Epidemiology finds who is getting sick, where and why, separating new cases from existing ones. Statistics converts raw counts into rates, so places of different sizes can be fairly compared. Behavioral, cultural, and environmental assessment handle what numbers alone cannot capture. Epidemiology's founding case is the tracing of a London cholera outbreak to a single contaminated water pump in 1854. It is proof that epidemiology did not merely inform public health, it made public health a science. Public health asks for money, authority, and sometimes the power to constrain individual choice. Rates, comparisons, and tested associations are what make those requests legitimate. Question 8. The classic Winslow definition calls public health the science and art of preventing disease, prolonging life, and promoting health. A city nurse holds solid epidemiologic evidence that a lead abatement program would lower childhood blood lead levels, but the city council is split and 2 landlord associations are organizing against it. Her next task belongs to which half of that definition? Your options are A. The science, because the exposure data must be recalculated before any program can move forward. B. The science, because a sound evidence base is what determines whether a program is adopted. C. The art, because turning evidence into action requires trust, cultural understanding, partnership, and political skill. D. Neither, because political work falls outside the recognized scope and standards of public health nursing. Got a guess? Lock it in. The correct answer is C. The art, because turning evidence into action requires trust, cultural understanding, partnership, and political skill. C is correct because the art half of the definition covers everything required to translate evidence into action inside real communities. Building trust, mobilizing partners, communicating persuasively, and working through local politics are the work in front of her. A sound epidemiologic finding changes nothing if no one can persuade a community to act on it. A is wrong because the data are already described as solid. Recalculating them would not move an initiative that is stalled on political opposition rather than on weak evidence. B is wrong because evidence establishes what should be done, not whether it will be done. Public health repeatedly encounters well-supported interventions that fall for want of political and community support. D is wrong because advocacy, collaboration, and leadership are named standards of professional performance for public health nurses. Working to secure policy change for a population sits squarely inside the specialty's scope. The classic 1920 definition of public health calls it the science and art of preventing disease and promoting health. Those 2 words, science and art, aren't decoration. They name 2 separate skill sets, and confusing them explains most of the field's failures. The science half is epidemiology and statistics, settling what the problem is and what works. The art half is trust building, coalition work and politics settling whether anything actually happens. Public health can't implement findings by fiat, so every real achievement runs through persuasion. Consider a city nurse who proves with solid data that lead in old rental housing is poisoning children. The science is finished. What remains is a divided city council, organized landlord groups, frightened tenants, and a closing budget window. All of it art, not science. When a scenario shows uncertainty about magnitude or effectiveness, that points to the science half. When it shows a stalled intervention, despite sound evidence, opposition, or cultural mismatch, that points to the art half. Sanitary reform, tobacco control, and vaccine coverage all show the same pattern. The evidence settled early, but success depended on trust, politics, and persuasion for decades afterward. The art is not a soft supplement to science. It is the other half of the job. Question 9. A public health nurse staffing a mobile unit has 1 hour left in the shift. She can spend it completing a detailed medication review for a single walk-in client whose hypertension is already well controlled. Or she can finish setting up a blood pressure screening station that a line of residents is waiting for. Which choice reflects the discipline's defining orientation and on what basis? Your options are A. The screening station. Because public health practice is accountable to the health of the population rather than to whichever individual happens to be present. B. The medication review, because a documented individual encounter carries more professional weight than a screening event. C. The screening station, because screening is classified as primary prevention and therefore outranks other activities. D. The medication review, because public health ethics places individual autonomy above the common good in every situation. Which one is it? Pause the video if you need more time. The correct answer is A. The screening station, because public health practice is accountable to the health of the population rather than to whichever individual happens to be present. A is correct because public health is population-focused rather than individual patient-focused, and public health nurses are professionally accountable to the population. When answer choices split between serving the one client mentioned and serving the whole group, the population-level choice is the one the discipline is built on. The client with controlled hypertension is not being abandoned. The population's need simply carries more weight in this context. B is wrong because documentation and encounter type do not settle priority in population practice. Reach and population benefit do. C is wrong because the choice is right, but the reasoning is wrong, which makes the whole option wrong. Screening is secondary prevention because it looks for disease that may already be present in people who still feel well. D is wrong because public health ethics balances individual autonomy against the common good, rather than placing autonomy above it in every case. Quarantine, mandatory reporting, and immunization requirements all limit individual choice to protect a population. One nurse, 1 hour, help the walk-in client with his medication review, or set up the blood pressure screening line outside. Both are defensible nursing, but only one reflects the orientation that defines public health as a discipline. Clinical medicine asks what is wrong with this patient and how to fix it. Public health asks what threatens this population and how to prevent it. And the two orientations differ across patient focus, timing, setting, success, and tools. Resources are finite, so every allocation decision quietly decides whose health gets served. A nurse who always serves whoever is standing there ends up serving the people best able to show up, leaving the least mobile and least insured with the least attention. Back at the mobile unit, the screening station reaches dozens of people in 1 hour, some carrying hypertension they don't know about, while the medication review serves one person who is already stable and connected to care. He isn't abandoned, he can be scheduled once the station is running. This doesn't license neglect. Public health nurses give direct individual care constantly. as long as it advances the population's health. Autonomy protects a person's right to consent or refuse, but it never creates a claim on the nurse's next hour ahead of everyone else. Question 10. A nursing student is confused by two terms that appear on the same textbook page. Which statement correctly describes the relationship between public health nursing and community health nursing? Your options are: A. The two terms are strict synonyms and can be substituted for one another in any sentence. B. Community health nursing is always population focused, while public health nursing may be either individual focused or population focused. C. Public health nursing refers only to government employment, while community health nursing refers only to private sector employment. D. Public health nursing is always population focused, while community health nursing is a wider umbrella label that can also cover individual focused community-based care. Take a second. Which answer would you pick? The correct answer is D. Public health nursing is always population focused, while community health nursing is a wider umbrella label that can also cover individual focused community-based care. D is correct because public health nursing is defined by its population focus, which the American Public Health Association makes explicit in describing it as population-focused nursing. Community health nursing is a looser label for nursing practiced in community settings and often includes community-based individual care alongside population work. When a source uses community health nursing, the surrounding context has to be read to see which sense is meant. R is wrong because treating the terms as interchangeable erases the one distinction that gets tested, which is whether the population focus is guaranteed by the label itself. B is wrong because this reverses the relationship. Public health nursing is the term carrying the guaranteed population focus. C is wrong because setting and employer define neither term. Public health nurses work in schools, work sites, correctional facilities, and faith communities as well as in health departments. Two terms sit on nearly every page of this field, and mixing them up costs points. Public health nursing is always population focused. Community health nursing is a broader umbrella that may or may not be. Public health nursing applies public health principles to protect populations, and the American Public Health Association calls it plainly population-focused nursing. That focus isn't just an emphasis, it's guaranteed by the label. A nurse giving vaccines one afternoon is still working towards the population's protection. A third term completes the picture. Public health is the whole multidisciplinary field, staffed by epidemiologists, health educators, sanitarians, and nurses, among others. Public health nursing is the population-focused specialty nested inside that field. Community health nursing is a wider label for nursing in community settings that overlaps both, sometimes population-focused, sometimes not. Three wrong turns show up constantly: treating the terms as strict synonyms, reversing the relationship by handing community health nursing the guaranteed population focus, and tying the distinction to employer type. When public health nurses work everywhere from schools to disaster response. The real test is always the activity itself, not the label. When a source says public health nursing, assume population focus. When it says community health nursing, check the activity first, because that orientation is the very thing easiest to lose under a heavy caseload. Question 11. A state health department publishes a quarterly report tracking asthma hospitalization rates by county and posts the underlying data on a public dashboard so local agencies and researchers can use it. Which core function of public health does this activity represent? Your options are: A. Policy development, B. Assessment, C. Assurance, D. Evaluation. Before I reveal it, which one do you think is right? The correct answer is B, assessment. B is correct because assessment is the systematic collection, analysis, and dissemination of information about the health of a population. Both halves matter here, since the department is not only monitoring rates but also making the information available to others. Assessment is public health, finding out what is happening. A is wrong because policy development would begin once the department used those rates to decide on a plan, program, or rule. Publishing data stops short of deciding anything. C is wrong because assurance means making certain that essential services actually reach the population, whether by providing them, mandating them, or linking people to them. A dashboard delivers information, not services. D is wrong because evaluating the effectiveness, accessibility, and quality of services is one of the 10 essential services and falls under assurance. It is not one of the 3 core functions, and nothing here is being evaluated. A county health department can see something no single clinic can, the whole picture of a population's health. Building that picture and sharing it with people who can act is the core function called assessment. Assessment means the systematic collection, analysis, and dissemination of information about a population's health. Students often drop that third verb, but data locked in a server changes nothing. A published dashboard reaching providers, schools, and the public is assessment work, not an afterthought. The mechanics behind assessment are concrete. Vital statistics supply births and deaths. Notifiable disease, reporting supplies communicable disease counts. Surveys capture behavior and access. Registries track cancer and immunization. And community assessment adds interviews and forums. Together, these convert raw counts into rates that let places and time periods be compared honestly. Assessment finds out, it does not decide. The moment findings are used to set a priority or write a plan, the work becomes policy development. And once services are provided or linked to people, it becomes assurance. 2 essential services belong here: routine monitoring and acute outbreak investigation. Assessment describes the population's health, while evaluation, part of assurance, judges the system's performance. Assessment is often the first budget cut because nobody dies visibly from a discontinued survey. Question 12. Sexually transmitted disease rates rise across a jurisdiction. After reviewing the surveillance data, the health department decides to make condoms far more easily accessible throughout the community. Which core function does that decision itself represent? Your options are A. Policy development, B. Assessment, C. Assurance, D. Health promotion. What's your answer? Commit to one before I continue. The correct answer is A. Policy development. A is correct because policy development is the use of scientific knowledge to lead the creation of policies, plans, and programs that support population health. The department has moved from knowing to deciding, which is exactly what this function names. Rising disease rates met with the decision to expand condom access is the signature example of the function. B is wrong because assessment was the earlier step, when the department collected and analyzed the surveillance data showing rates were rising. The decision that follows belongs to a different function. C is wrong because assurance is the step after the decision, when the department actually places condoms in clinics, schools, and community sites and confirms they are reaching people. The scenario stops at the decision. D is wrong because health promotion is a broad activity aimed at enabling people to improve their health. It is not one of the 3 core functions and cannot be the answer to a question that asks for one. Surveillance told the health department that STD rates were rising and which groups were most affected. Knowing that is where assessment ends. What comes next, deciding to expand condom access, is a different core function entirely. Policy development. Policy development means using scientific knowledge to lead the creation of policies, plans, and programs. The operative word is lead. it converts evidence into a chosen course of action, with priorities set, trade-offs accepted, and a plan committed on the record. 3 of the 10 essential services carry this function: informing, educating, and empowering people, mobilizing community partnerships with coalitions, employers, and schools, and developing the policies and plans that are the formal output, whether a strategic plan, a regulation, or a proposal. The boundary that generates errors runs between deciding and delivering. Deciding to expand condom access is policy development, actually placing supplies in clinics, schools, bars, and community centers as assurance, and the same split applies to something like a lead exposure plan versus enforcing abatement. Policy development sounds bureaucratic, but it's the most political of the core functions, and the one public health most often wins or loses. A decision that survives budget cycles and opposition is a real win. One that dies in committee leaves the data just as useless as before. Question 13. Surveillance shows unusually high rates of injury and respiratory illness among workers at a large manufacturing plant with no on-site clinician. The health department arranges for occupational health services to be delivered at the plant itself. Which core function is the department performing? Your options are A. Assessment, B. Policy development, C. Assurance, D. Case finding. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Assurance. C is correct because assurance means making certain that essential health services are actually available to the population, whether by direct provision, mandate, or linkage to another provider. Arranging on-site services for a workforce that had none is assurance in its clearest form. The factory example is the course's signature illustration of this function. A is wrong because assessment happened when surveillance revealed the elevated injury and illness rates. The department has already moved past that step. B is wrong because policy development covered the decision to act on the pattern. Assurance is what turns that decision into services people can actually use. D is wrong because case finding is a nursing role and an intervention, not a core function of public health. It also describes outreach to identify individuals who need help, which is narrower than arranging services for a whole workforce. A plan nobody delivers looks exactly like no plan at all. Assurance is the core function that closes that gap, making sure essential health services are actually available to the people who need them. Assurance works through 3 distinct routes. An agency can directly provide a service, like running its own clinic. It can mandate a service requiring hospitals or schools to comply, or it can link people to services someone else provides through referral and contracting. All 3 count, and direct provision is often the least sustainable. Consider a factory with no clinician on staff, where surveillance turns up high rates of injury and respiratory illness. The health department can't hire a physician for a private company, but it can negotiate with the employer and connect an on-site provider. Services now exist where none existed. 4 of the 10 essential services fall under assurance, enforcing laws like restaurant inspections and housing codes, linking people to personal health services, assuring a competent workforce through licensure and training, and evaluating whether services actually work. That last one surprises people, since evaluating services judges the delivery system, not the population's health, which is why it belongs here instead of assessment. The clearest test: has something been decided or has something been delivered? Deciding to expand access is policy development. Placing supplies, enforcing rules, and confirming people can reach the service is assurance. Question 14. A nurse manager wants a one-line way to help new staff keep the 3 core functions of public health in order. Which sequence correctly captures how the 3 relate to one another? Your options are A. Assurance finds the problem, assessment decides the response, and policy development delivers it. B. Policy development finds the problem, assurance decides the response, and assessment delivers it. C. Assessment finds the problem, assurance decides the response, and policy development delivers it. D. Assessment finds the problem, policy development decides the response, and assurance delivers it. Which would you go with? Lock it in before the reveal. The correct answer is D. Assessment finds the problem, policy development decides the response, and assurance delivers it. D is correct because the clean shorthand is assess, then decide, then delivers. Assessment collects and analyzes the data that reveal a problem. Policy development converts that knowledge into a plan or program. And assurance makes certain the response actually reaches the population. Holding the order straight resolves most core function items on site. A is wrong because this scrambles all three. Assurance is the delivery function, not the discovery function, and assessment does not make decisions. B is wrong because policy development cannot find a problem because it operates on knowledge that assessment has already produced. Assessment is also misplaced at the delivery end. C is wrong because the first term is right, but the last two are swapped. Policy development decides and assurance delivers, not the reverse. Three words hold public health together: assess, decide, deliver. Assessment finds the problem, policy development decides the response, and assurance makes that response real. Lock in this order and the core functions become obvious on sight. The sequence isn't arbitrary. Deciding without assessing produces a diabetes program in a town where overdose is the real killer. Assessing without deciding produces great reports and no change. And deciding without assuring just produces a plan collecting dust on a shelf. Walk one problem through all three. Surveillance shows lead levels clustering by building age. That's assessment. The department designs an abatement program and builds a coalition. That's policy development. Inspectors enforce the code and track remediation. That's assurance. A single scenario can sound like any of the three, so the deciding clue is the verb. Monitoring and mapping point to assessment, planning and mobilizing point to policy development, and enforcing or referring point to assurance. When it's unclear, ask whether the action produces knowledge, a decision, or a delivered service. This triad lets a department audit itself and ask exactly where it's weakest. It's often confused with the nursing process of assess, plan, implement, evaluate, but that describes how a nurse works a case, while the core functions describe what the whole public health system does. Question 15. A local health department inspects restaurants and enforces the food safety code, and separately operates a program that links uninsured residents to primary care providers. Which core function do both of these essential public health services support? Your options are A. Assessment, B. Assurance, C. Policy development, D. Research, which stands apart from the three core functions. Don't overthink it. Which one feels right? The correct answer is B. Assurance. B is correct because enforcing laws and regulations that protect health and linking people to needed personal health services are both assurance services. Assurance covers the range of ways public health makes services and protections real, from direct provision to mandate to linkage. Services 6 through 9 of the 10 essential services all belong to this function. A is wrong because assessment covers the first two essential services, which are monitoring health status and diagnosing or investigating health problems and hazards. Neither activity described here is data gathering. C is wrong because policy development covers informing and educating the public, mobilizing partnerships, and developing policies and plans. Enforcing an existing code and linking clients to providers are downstream of that work. D is wrong because research for new insights and innovative solutions is the 10th essential service, and it supports all three functions rather than standing apart from them. Neither activity in the scenario is research. The three core functions were just an organizing idea, and ideas don't survive budgets unless someone makes them concrete. In 1994, a federal working group did exactly that, translating assessment, policy development, and assurance into 10 essential public health services that agencies could actually fund, staff, and audit. 2 services carry assessment, monitoring health status and diagnosing outbreaks. 3 carry policy development, informing and educating the public, mobilizing community partnerships, and developing policies and plans. 4 carry assurance, enforcing laws, linking people to care, assuring a competent workforce and evaluating services. Research, the 10th, supports all 3 functions rather than belonging to just one. The relationship between the 2 frameworks is simple containment. 3 functions, 10 services, each service nested inside one function, with research alone spanning all 3. 2 mistakes come up again and again. Informing and educating people looks like a delivered service, so students misfile it under assurance, when its real purpose is building the constituency that policy needs. Evaluating services looks like data work, so it gets filed under assessment, when it's really assurance because it checks the delivery system, not the population's health status. This list matters beyond memorization, public health accreditation, funding formulas, and workforce competencies are all built directly on these 10 services, making this the actual architecture agencies are measured against. Question 16. A public health nurse assessing a low-income neighborhood with high rates of uncontrolled diabetes documents that the nearest full grocery store is 4 miles away. Bus service ends before 6 in the evening, and roughly half of adult residents did not finish high school. What is the nurse documenting? Your options are A. Secondary prevention indicators for the neighborhood. B. Clinical risk factors specific to the pathophysiology of diabetes. C. Determinants of health that shape this population's health status. D. Evidence that the population is unmotivated to manage its own health. Got a guess? Lock it in. The correct answer is C. Determinants of health that shape this population's health status. C is correct because food access, transportation, and education are all named determinants of health, meaning personal, social, economic, and environmental factors that influence the health status of populations. They are the reasons behind the reasons that diabetes control is poor in this neighborhood. Population-focused practice works on these upstream conditions rather than only on the resulting illness. A is wrong because secondary prevention refers to screening and early detection of disease. Nothing in the nurse's documentation involves testing anyone for anything. B is wrong because clinical risk factors for diabetes would include obesity, family history, and insulin resistance. Grocery distance and bus schedules are social and environmental conditions, not pathophysiology. D is wrong because attributing the pattern to motivation ignores the constraints the nurse just documented. Personal health practices operate within the limits set by environment, income, and access, which is the central insight behind determinant-focused work. Health researchers had to name the reasons behind the reasons. Poor glycemic control traces back to inconsistent diet, which traces back to a distant grocery store, low income, and a struggling school system. Those deeper layers are the determinants of health. The core insight is that where people live, learn, work, and play shapes their health more than medical care does. Medical services account for roughly 1/10 of premature death, while lifestyle, environment, and biology account for the rest. The list is worth memorizing: income and social status, education, employment and working conditions, social support networks, biology and genetics, physical environment, housing, transportation, and personal health practices. Access to health services and culture round out the full framework. Picture a nurse documenting grocery distance, bus schedules, education levels, housing conditions, and safety in a neighborhood with poor diabetes control. None of that is pathophysiology, yet all of it is health data describing the machinery producing the disease. Determinants are often confused with clinical risk factors, but the difference is level. Risk factors are traits of a person, while determinants are conditions of a population that produce those risks at scale. Treating behavior as freestanding is the most common way this reasoning collapses into individual blame, and that asymmetry is the whole argument for working on determinants. Question 17. A health department describes its new strategy as working upstream. Which action best fits that description? Your options are A. Partnering with the housing authority to remediate mold and lead in aging apartment buildings. B. Treating each child who arrives at the clinic with an asthma exacerbation. C. Increasing the number of rescue inhalers stocked in the clinic pharmacy. D. Adding weekend clinic hours so more sick children can be seen quickly. Which one is it? Pause the video if you need more time. The correct answer is A. Partnering with the housing authority to remediate mold and lead in aging apartment buildings. That is correct because upstream work changes the conditions that push people into illness rather than rescuing them one at a time after they fall in. Mold and lead in housing are the environmental determinants generating asthma exacerbations and neurologic harm in this population. Removing the hazard prevents cases that would otherwise arrive at the clinic. B is wrong because treating children who present with exacerbations is downstream rescue work. It is necessary and valuable, but it addresses the consequence rather than the cause. C is wrong because stocking more inhalers improves capacity to respond to disease that has already occurred. The number of children exposed to the trigger does not change. D is wrong because expanding access to treatment shortens the distance between a sick child and care, which is still downstream. The exposure producing the illness continues unchanged. Imagine standing by a river watching people fall in and drown. You can jump in and pull them out one at a time, or you can walk upstream to find out why they keep falling in. That parable captures public health's central strategic choice. Take a child arriving at the ER with an asthma attack. Downstream, you treat the exacerbation. A step back, the clinic improves medication and follow-up. Further upstream, the health department fixes mold and ventilation in the buildings those children actually live in. The reason upstream work wins over time is compounding. Every downstream rescue has to be repeated for the next patient, but an upstream fix like removing a hazard stays removed for every future occupant and every future cohort of children. Upstream simply means acting on a cause several steps back from the visible harm, along this kind of causal chain. That is a different idea from primary prevention, which is about timing, not distance. A vaccine is primary prevention but sits fairly close to downstream. A screening program is secondary prevention, yet can still be upstream of death. Downstream rescue is visible and earns gratitude. While upstream success is invisible by design, it's the illness that never occurred. That invisibility is exactly why upstream work needs advocates, not just evidence. Question 18. A community assessment team organizes all of its findings under 5 headings: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Which framework is the team using? Your options are A. The 3 core functions of public health. B. The 5 domains of the social determinants of health. C. The 3 levels of prevention. D. The 3 levels of practice focus. Take a second. Which answer would you pick? The correct answer is B. the 5 domains of the social determinants of health. B is correct because those 5 headings are the domains the National Healthy People Framework uses to organize the social determinants of health. Grouping assessment findings this way keeps the team looking at the conditions in which people live rather than only at disease counts. It doubles as a checklist that makes gaps in an assessment visible. A is wrong because the 3 core functions are assessment, policy development, and assurance. They describe what public health does, not the categories of conditions it assesses. C is wrong because the levels of prevention are primary, secondary, and tertiary, and there are 3 of them rather than 5. They classify when an intervention acts relative to disease. D is wrong because the 3 levels of practice focus are individual, community, and systems. They describe the target of an intervention, not the domains of a community assessment. A community assessment can count emergency visits and chart disease rates and still miss what actually matters, like the third of households with no car or the school with the lowest reading scores in the district. Reports that only describe disease miss the conditions that produce it. The 5 domains of the social determinants of health exist to close that gap. The 5 domains are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Together they cover income and employment, schooling, insurance and providers, housing and safety, and social support and civic life. This grouping comes from the Healthy People Framework, the national health objectives the US updates each decade. Its aims are helping people live long, healthy lives free of preventable disease, eliminating disparities to achieve health equity, creating environments that promote good health, and supporting healthy development across every life stage. Domains that ignored income, education, and neighborhood conditions could not serve those aims. These 5 domains are not a competing framework to the longer list of health determinants. That list includes biology and genetics, which isn't social at all, while the 5 domains group only the social and environmental factors for assessment and goal setting. Biology and genetics has no domain, and that absence is a feature, not an oversight. Used as a checklist, the 5 domains reveal where an assessment is thin, since data collection naturally drifts toward whatever is easiest, and clinical data is always easiest, but their deeper meaning is who you must work with: housing authorities, transit agencies, school districts, and employers, none of whom report to a health department. Question 19. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. Which additional element does that definition explicitly include? Your options are A. The genetic and inherited traits that shape individual susceptibility to disease. B. The clinical practice guidelines that direct evidence-based treatment decisions. C. The personal coping skills people rely on to manage stress in daily life. D. The systems that distribute money, power, and resources across a society. Before I reveal it, which one do you think is right? The correct answer is D. The systems that distribute money, power, and resources across a society. D is correct because the definition names both the conditions of daily life and the systems that distribute money, power, and resources. That second clause is what makes the concept structural rather than merely descriptive, since it points at how a society allocates advantage. It is also the clause that connects the social determinants directly to social justice and health equity. A is wrong because biology and genetics are counted among the determinants of health, but they are not social determinants and they are not part of the World Health Organization's phrasing. B is wrong because clinical guidelines govern treatment inside the healthcare system. Healthcare access and quality is one social determinant domain, but practice guidelines themselves are not part of this definition. C is wrong because personal health practices and coping skills appear on the list of factors influencing health status. They describe individual behavior rather than the societal conditions and distribution systems this definition targets. Most people quote the WHO definition of social determinants of health and stop one clause too early. They remember conditions in which people are born, grow, live, work, and age. But the definition keeps going. And that second part is where the concept gets its teeth. The full definition names conditions of daily life, then adds the systems that distribute money, power, and resources at global, national, and local levels. That second clause turns the concept from something descriptive, like weather, into something structural, a product of tax policy, labor law, zoning, and school funding decisions. The mechanism runs in traceable steps. A school funding formula tied to property values produces weaker schools. Weaker schools produce lower attainment. Lower attainment produces less secure income, and that produces worse housing and thinner access to care. What looks like an individual result is really the accumulated product of a distribution decision made years earlier. This is why social determinants are kept distinct from the broader list of determinants of health. Biology and genetics belong on the broader list, since no system distributes them, and personal health practices describe individual behavior, not societal conditions. Social determinants are specifically the conditions and the systems that distribute them. That's why unequal health outcomes across neighborhoods a few miles apart aren't unfortunate coincidences. They're the predictable output of who gets resources and power. The definition was built to point at policy, which is exactly why it belongs in political argument, not just health reports. Question 20. A nurse finds that adults in one rural county miss dialysis appointments far more often than adults in the neighboring county. Even though disease prevalence is similar in both counties and both dialysis centers report open appointment slots. Which determinant of health should the nurse investigate first? Your options are A. Biology and genetics, B. Personal health practices and coping skills, C. Transportation, D. Social support networks. What's your answer? Commit to one before I continue. The correct answer is C. Transportation. C is correct because transportation is a named determinant of health and one of the most reliably tested barriers to care. When capacity exists, disease burden is comparable, and people still cannot get to appointments. The gap between home and clinic is the first thing to examine. Rural distance combined with limited public transit produces exactly this pattern. A is wrong because biology and genetics shape who develops kidney disease, not who can physically reach a treatment chair 3 times a week. The scenario states prevalence is similar across both counties. B is wrong because framing missed appointments as a personal choice skips over the structural barriers that produce them. Behavior is the last thing to examine here, not the first. D is wrong because weak social support can compound a transportation problem, especially if no family member can drive. It is a reasonable secondary line of inquiry, but the direct and most testable explanation for missed appointments across a whole rural county is access to transportation. 2 neighboring counties, same kidney disease rates, same open dialysis chairs. Yet one county sees far more missed sessions, more hospitalizations, more deaths. The difference isn't the disease or the clinic. It's whether a person without a car can physically get to a chair 3 times a week. A missed dialysis session gets documented as non-adherence. A missed prenatal visit becomes a no-show. An uncollected prescription is non-compliance. Every one of those labels describes the patient and hides the fact that the real problem is 30 miles and no bus. Think of transportation as the link between a service that exists and a person who needs it. The dialysis center is staffed. The appointment is open, the treatment works. But when that link breaks, none of that upstream readiness matters anymore. Real fixes look nothing like counseling. They include subsidized rides, mobile units routed into underserved areas, satellite clinics that move care closer, and shifted hours or telehealth for people tied to one daily bus. Each targets the condition, not the patient's motivation. When a population underperforms despite adequate capacity, check distance, transit costs, and hours before blaming motivation. Motivation isn't checkable at population scale, and structural access is. Question 21. A nurse is preparing a single slide summarizing the approximate contribution of 4 broad categories to premature death. Which set of proportions matches the widely taught health field breakdown? Your options are A. Lifestyle and behavior about 50%, biology and genetics about 20%, environment about 20%, healthcare about 10%. B. Healthcare about 50%, lifestyle and behavior about 20%, environment about 20%, biology and genetics about 10%. C. Lifestyle and behavior about 20%, biology and genetics about 50%, environment about 20%, healthcare about 10%. D. Environment about 50%, healthcare about 20%, lifestyle and behavior about 20%, biology and genetics about 10%. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Lifestyle and behavior about 50%, biology and genetics about 20%, environment about 20%, healthcare about 10%. A is correct because the breakdown assigns roughly half of premature death to how people live, a fifth each to biology and to environment, and only about a tenth to medical services. Lifestyle carries the largest share because tobacco use, diet, inactivity, alcohol, and unsafe behavior together drive an enormous volume of early death. This distribution is the reason public health invests upstream rather than betting everything on treatment. B is wrong because placing healthcare at half inverts the entire point of the framework. Medical services matter enormously to the people who receive them, but account for the smallest slice of premature death across a population. C is wrong because swapping lifestyle and biology makes early death look largely inherited and therefore largely fixed. Biology and genetics contribute about a fifth, not half. D is wrong because environment is a substantial determinant at roughly a fifth, but it does not top the list, and healthcare does not sit at a fifth. Only one arrangement of these 4 numbers is the taught one. 4 numbers organize an enormous amount of thinking about population health. This framework, called the health field concept, came from the 1974 Lalonde Report on the Health of Canadians, and it broke a false assumption that health and healthcare were the same thing. Lifestyle and behavior contribute roughly 50% of premature death. Biology and genetics contribute about 20%, environment another 20%, and healthcare and medical services only about 10%. Death certificates record diagnoses like heart disease, cancer, and stroke, but those describe the mechanism of death, not its cause. Behind those diagnoses, the actual causes turn out to be tobacco use, poor diet, and inactivity, and alcohol. These proportions describe a population, not a single patient. So a person with a hereditary cancer syndrome or a trauma survivor can defy the averages entirely. And the 20% assigned to biology isn't a ceiling, since genetic risk interacts with behavior and environment rather than acting alone. The framework's real lesson is where opportunity sits. The smallest return sits in the most expensive category, medical care, and the largest return sits in the least funded ones, lifestyle and environment. Question 22. A hospital administrator argues that the fastest way to lower premature death in the county is to expand specialty medical services. Drawing on the health field breakdown of premature death, what is the strongest population level counter argument? Your options are A. Specialty services are too expensive relative to the clinical benefit they deliver. B. Medical care accounts for roughly a tenth of premature death, while lifestyle, environment, and biology together account for the rest. C. Premature death is driven almost entirely by inherited biology, so no intervention will change the county's outcomes much. D. Hospitals cannot participate in population health work because their orientation is individual treatment. Which would you go with? Lock it in before the reveal. The correct answer is B. Medical care accounts for roughly a tenth of premature death, while lifestyle, environment, and biology together account for the rest. B is correct because the counter-argument is arithmetic rather than ideological. Medical services address the smallest of the four categories contributing to premature death, so expanding them alone leaves roughly 90% of the drivers untouched. Population gains come from acting on behavior, environment, and social conditions alongside clinical capacity. A is wrong because cost effectiveness is a separate debate and does not follow from the health field concept. Specialty care can be well worth its price and still be the smallest lever on premature death. C is wrong because biology and genetics account for about a fifth of premature death, not almost all of it. This option also leads to fatalism, which is the opposite of the framework's message. D is wrong because hospitals routinely partner in population health work through community benefit program, screening, and data sharing. The framework describes where leverage lies, not who is permitted to act. A hospital administrator argues that more cardiology, oncology, and critical care beds are the fastest way to cut premature death in the county. The request sounds reasonable, but it has an arithmetic problem hiding in plain sight. Medical care accounts for only about 10% of premature death. The other 90% comes from behavior, environment, and biology. Expanding specialty services acts on the smallest of these four categories, leaving most of the real drivers untouched. This reasoning feels wrong to no one inside a hospital, because doctors watch dying patients leave alive every shift. What that view can't show is the denominator. Everyone in the county who never made it to the door, whose disease was preventable years before diagnosis. Population thinking supplies that missing denominator, and once it's visible, the conclusion changes. Proportionality, not abandonment of treatment, is the right response. This isn't prevention versus treatment. A county needs both, and losing trauma capacity costs lives just as surely as neglecting tobacco control or housing quality does. The honest reading of the health field concept is optimistic about population health and skeptical only of mistaking more treatment for prevention. Question 23. A worksite program offers cooking classes, a walking club, a stress management series, and sleep education to a workforce that shares no particular diagnosis. The program does not target any single disease. Which concept does this program best illustrate? Your options are A. Secondary prevention through early detection. B. Tertiary prevention through complication management. C. Disease prevention through specific protection. D. Health promotion through enabling people to improve their health. Don't overthink it. Which one feels right? The correct answer is D. Health promotion through enabling people to improve their health. D is correct because health promotion is the process of enabling people to increase control over and improve their health, and it is aimed at raising the baseline rather than at blocking one named disease. Nutrition, activity, stress, and sleep are exactly the lifestyle factors behind the largest share of premature death. The absence of a disease target is the clearest signal in the stem. A is wrong because secondary prevention means screening an at-risk or possibly affected group to find disease early. No one in this program is being tested for anything. B is wrong because tertiary prevention acts after disease is established, limiting disability and preventing complications. The workforce is described as having no shared diagnosis. C is wrong because specific protection is a form of disease prevention aimed at a known threat, such as a vaccine against influenza or fluoride against dental caries. It requires a named disease target, which this program lacks. A worksite program with cooking classes, a walking club, stress management, and sleep sessions has no disease target at all. That absence is the clue. This is health promotion, not disease prevention. And telling the two apart is one of the most useful distinctions in this field. Health promotion enables people to gain more control over their own health. It works with essentially healthy populations, moving them toward wellness through nutrition, activity, tobacco reduction, and stronger coping skills. It isn't organized around any single disease, it simply raises the baseline. Disease prevention protects people from an actual or potential threat. Immunization stops influenza. Screening catches cervical cancer early. Foot care prevents amputation. Within primary prevention, there are two flavors. General health promotion raises the baseline, while specific protection matches a countermeasure to a known threat, like a flu vaccine or fluoridated water. Both happen before disease exists. The same activity can land at different prevention levels depending on who receives it. Teaching nutrition to a healthy class is primary prevention. Teaching it to students with pre-diabetes is secondary. Teaching it to diagnosed diabetics learning carbohydrate counting is tertiary. The teaching itself doesn't set the level. The population status and purpose do. Roughly 70% of preventable early death traces back to promotion and prevention, not medical treatment, which is why the field centers on them. But in practice, they're rarely separate. A walking club promotes health, and adding a blood pressure screening quietly folds in secondary prevention too. Question 24. A nurse explains to a community board that prevention receives only about 3% of national healthcare spending, even though health promotion and disease prevention relate to roughly 70% of avoidable early death. Which statement best explains that mismatch and its implication? Your options are: A. Prevention's payoff is diffuse and delayed, while treatment demand is immediate and visible. So prevention is justified by the health it produces rather than by guaranteed savings. B. Prevention reliably lowers total lifetime healthcare costs, which is why cost savings remain the strongest argument for funding it. C. Prevention receives little funding because the evidence base supporting preventive interventions is weaker than the evidence base for treatment. D. Prevention receives little funding because most premature death results from causes that no intervention can influence. Got a guess? Lock it in. The correct answer is A. Prevention's payoff is diffuse and delayed, while treatment demand is immediate and visible. So prevention is justified by the health it produces rather than by guaranteed savings. A is correct because prevention competes badly for money because its benefits are spread across a population and arrive years later, while a person needing treatment today is visible and urgent. There is also a counterintuitive fiscal wrinkle worth knowing, since keeping people alive longer produces older populations that consume more care across more years. Prevention earns its place because it produces health, which is the mission, not because it always saves money. B is wrong because the claim that prevention always saves money is a common oversimplification and can be false over a full lifetime. Building the case for prevention on guaranteed savings leaves it vulnerable when the savings fail to appear. C is wrong because the evidence for sanitation, immunization, tobacco control, and screening is among the strongest in health science. Weak evidence is not the reason for the funding gap. D is wrong because the health field breakdown shows the opposite, since lifestyle and environment together account for roughly 70% of premature death and both are modifiable. Roughly 70% of early death is preventable, yet prevention receives only about 3% of health spending. Understanding why this gap persists matters more than memorizing the numbers. A tobacco tax passed today shows up as avoided cancer 20 years from now, spread across people who never know they were saved. A person with chest pain today generates an immediate, unignorable claim on resources. Treatment has real constituencies, patients who can testify, clinicians who advocate, institutions defending budgets, and manufacturers selling products. Prevention's beneficiaries don't know who they are, so they can't organize, can't lobby, and can't show up to defend the program. This is the structural asymmetry at the heart of the paradox. Prevention's benefit is diffuse and delayed, scattered across a population that will never know it was helped, while treatment's demand is concentrated, immediate, and attached to a real name. Successful prevention can actually raise lifetime health costs, since people saved from early death go on to need joint replacements and dementia care later. But prevention's justification is health produced, not savings delivered. So building the case on guaranteed cost reductions is a fragile strategy that collapses the moment savings fail to appear. Question 25. A population in a stable suburb shows very low rates of diagnosed disease, yet a community assessment documents widespread social isolation, high reported stress, and almost no public spaces where residents gather. Using the World Health Organization definition of health, how should the nurse characterize this population? Your options are A. Healthy, because health is defined as the absence of disease or infirmity. B. Healthy, because mental and social factors fall outside the definition of health. C. Not fully healthy, because health includes physical, mental, and social well-being rather than only the absence of disease. D. Impossible to characterize, because the definition of health applies to individuals rather than populations. Which one is it? Pause the video if you need more time. The correct answer is C. Not fully healthy, because health includes physical, mental, and social well-being rather than only the absence of disease. C is correct because the World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That definition is deliberately positive and multi-dimensional, which means a disease-free population can still be unhealthy on other dimensions. Isolation and chronic stress are health problems in that framework, not merely quality of life concerns. A is wrong because this is the definition the World Health Organization explicitly rejected. Defining health as the absence of disease is the view the field moved past in 1948. B is wrong because mental and social well-being are named components of the definition, not peripheral considerations. Excluding them removes two of its three pillars. D is wrong because public health applies the definition to populations routinely, and community assessment exists to measure health across all its dimensions at the population level. In 1948, the World Health Organization wrote a deliberately provocative definition. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. That last clause was an argument, rejecting the idea that no diagnosis means healthy. The definition made health positive rather than residual, and multidimensional rather than purely physical. The physical dimension covers bodily function and freedom from disease. The mental and emotional dimension covers psychological well-being and stress management. And the social dimension covers relationships and supportive bonds. Many frameworks extend the model further, adding a spiritual dimension covering meaning and purpose, an intellectual dimension covering curiosity and learning, and environmental and occupational dimensions covering healthy surroundings and satisfying work. Wellness is the active, deliberate pursuit of choices toward a healthy life, while health is a state you occupy at any given moment. Picture a continuum stretching from severe illness to high-level wellness, where every person and population sits somewhere and can move in either direction. Consider a suburb with very low disease rates but widespread isolation, high stress, and no walkable gathering spaces. By a disease count, it looks healthy. By the WHO definition, it isn't. Because social and mental well-being are core parts of health, not side notes. Question 26. A nurse orienting new staff at a health department is asked to state the goals of public health nursing. Which set of statements captures them? Your options are: A. Diagnose disease accurately, treat it promptly, and rehabilitate those it disables. B. Promote health for all people, prevent disease and disability for all people, and achieve and maintain the conditions in which people can be healthy. C. Reduce the cost of care, shorten hospital stays, and raise provider productivity. D. Serve the individuals who present for care first, then extend services outward as resources allow. Take a second. Which answer would you pick? The correct answer is B. Promote health for all people, prevent disease and disability for all people, and achieve and maintain the conditions in which people can be healthy. B is correct because the three stated goals are promotion of health, prevention of disease and disability, and achievement and maintenance of the conditions in which people can be and remain healthy. Every one of them is about prevention and conditions rather than about curing individuals. The phrase for all people carries real weight since it commits the specialty to the whole population and especially to those for whom health is hardest to reach. A is wrong because diagnosis, treatment, and rehabilitation describe the aims of clinical care. A public health nurse may deliver hands-on care, but the purpose behind it is always the population's health. C is wrong because efficiency and cost targets belong to health system management. They can be worthy objectives without being the goals of the specialty. D is wrong because serving whoever presents first is the logic of a clinic waiting room. Public health nursing is accountable to the entire population, including people who never seek care. 3 words do more work than the rest of the sentence: for all people. Public health nursing commits to promoting health and preventing disease and disability for everyone, not just those who show up, who are insured or who are easy to reach. The goals themselves are 3. Promote health, prevent disease and disability, and achieve and maintain the conditions in which people can be healthy. Everyone concerns prevention and conditions, not curing individual patients. The goals leave out diagnosis, treatment, rehabilitation, cost reduction, efficiency, throughput, and productivity. Those are legitimate health system objectives, but when a scenario pits an efficiency gain against a population health gain, the goals point toward population health. Because the commitment is to the whole population, resources can't simply follow demand. A program serving whoever calls first reaches the most organized and least burdened people, systematically underserving those whose need is greatest. Bedside nursing owes a duty to the patient in the room. Public health nursing owes a duty to a population that cannot advocate for itself and never appears at the desk asking for anything, and the goals make that unspoken claim explicit. Question 27. A nurse completes an evaluation showing that a county-wide fall prevention program lowered hip fracture rates among adults over 65. According to the population-level nursing process, what distinguishes its final step from the end of an individual episode of care? Your options are: A. The program is formally closed once outcome data confirm that it worked. B. The nurse writes a discharge summary documenting the population's final health status. C. The nurse hands the results to an administrator because evaluation marks the end of nursing involvement. D. The results feed back into the cycle as assessment data for the next round of planning and action. Before I reveal it, which one do you think is right? The correct answer is D. The results feed back into the cycle as assessment data for the next round of planning and action. D is correct because the fifth step is to use the results to take further action, and it is what makes the population process cyclical rather than linear. Evaluation findings become the assessment data for the next round, so the nurse refines, expands, redirects, or sustains the work. Population health is never finished the way a patient's episode of care is. A is wrong because closing a program on success would surrender the gain. Falls continue to occur, new cohorts of older adults keep arriving, and the intervention has to be sustained or redesigned. B is wrong because discharge summaries belong to individual episodes of care. Populations are not discharged. C is wrong because handing results off and stepping away breaks the loop that defines the process. Feeding evaluation back into assessment is the nurse's work, not an administrator's. An individual patient's care ends. The wound heals, the chart closes. A population never gets that ending. Teen pregnancy rates that fall can rise again. A vaccinated cohort ages out. A fixed hazard reappears, which is exactly why the population nursing process has to be cyclical. The process runs in 5 steps. Assess the population's needs, plan and design interventions, implement at individual, community or systems level. Evaluate whether health status actually moved and take further action. That last step is what turns us into a loop instead of a line. Evaluation findings become next round's assessment data. A fall prevention program that lowered hip fractures worked for a specific cohort under specific conditions. Stop the exercise programming, the medication reviews, or the home modification funding, and the gain quietly reverses. The result was real but never permanent. The two processes rhyme without matching. Assessment, diagnosis, implementation, and evaluation each have a population scale counterpart, but the final step diverges, a discharge on one side, feeding results back into the cycle on the other. Handing results to an administrator and moving on breaks the loop, and it's the most common way population work quietly reverts to disconnected projects. A program that produced real gains and then ended teaches a jurisdiction that gains don't last. A worse lesson than never running the program at all. Question 28. A public health nurse is assigned to a county where teen birth rates are climbing. Which action represents the assessment step of the population level nursing process? Your options are A. Pulling vital statistics and school data, mapping rates by zip code, and interviewing school counselors and teens about the conditions behind the pattern. B. Opening a confidential reproductive health clinic in the zip code with the highest rate. C. Comparing teen birth rates before and after a new program to see whether the rates fell. D. Presenting a proposal asking the school board to adopt comprehensive health education. What's your answer? Commit to one before I continue. The correct answer is A. Pulling vital statistics and school data, mapping rates by zip code, and interviewing school counselors and teens about the conditions behind the pattern. A is correct because population level assessment gathers and analyzes data about a population's health status, its determinants, its strengths, and its problems. Vital statistics, geographic mapping, and key informant interviews are its standard instruments. And together they turn a vague sense that something is wrong into a specific, located, explained problem. This is the population counterpart to a head-to-toe assessment. B is wrong because opening a clinic is implementation, which is the third step. It can only be designed well after assessment has shown where and why the problem concentrates. C is wrong because comparing rates before and after a program is evaluation, the fourth step. There is no program yet to evaluate. D is wrong because bringing a proposal to the school board is planning moving into implementation at the systems level. It presumes an assessment has already identified the need. A physical exam has no population equivalent, so the nursing process begins with assessment, examining a population's health status, its determinants, its strengths, and its problems before anything else happens. Quantitative sources are fairly standardized. Vital statistics supply births, deaths, and outcomes. Notifiable disease, reporting supplies communicable disease counts. Hospital and emergency department data supply utilization patterns, and census data supplies determinants like income, education, and housing. The qualitative layer is what keeps numbers interpretable. Key informant interviews, community forums, and windshield surveys explain why a pattern exists. Numbers locate a problem, and people explain it. It's easy to confuse later steps with assessment. Opening a clinic is implementation. Comparing rates before and after is evaluation. And bringing a proposal to a school board is planning. All three presuppose assessment. None of them is assessment. Strong assessment examines determinants, not just outcomes, because a program launched without it ends up aimed at whatever staff already assumed, not the problem that's actually there. Question 29. A nurse must determine whether a 2-year childhood lead screening and abatement program improved the health of the target population. Which approach fits population-level evaluation? Your options are A. Surveying participating families about how satisfied they were with the program staff. B. Comparing blood lead level rates across the target population before and after the program. C. Reviewing the chart of the individual child whose lead level was highest at enrollment. D. Counting the total staff hours spent conducting home inspections. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Comparing blood lead level rates across the target population before and after the program. B is correct because population evaluation compares health indicators across the population before and after an intervention, using measures such as incidence, prevalence, and rates. Blood lead level rates are the outcome the program existed to change, so they are the honest test of whether it worked. Rate comparison is the population equivalent of checking whether a wound healed. A is wrong because satisfaction data describe how the program felt to participants. That is useful for refining delivery, but says nothing about whether lead exposure fell. C is wrong because one child's chart is a case, not a population outcome. It can illustrate the program, but cannot establish that the population's health status changed. D is wrong because staff hours are a process and effort measure. A program can log thousands of hours and still fail to move a single health indicator. A satisfaction survey can glow with praise and still tell you nothing about whether a lead program actually improved health. That gap between feeling good about a service and proving it worked is the core problem in population evaluation. Process measures like staff hours, homes inspected, and families enrolled describe effort and reach, and they're essential for managing a program. But they cannot establish that anything got better. A program can log thousands of hours and never move a single health indicator. The honest test is whether blood lead rates across the whole target population fell, checked against a similar untreated area, since housing turnover and national trends can move rates for reasons that have nothing to do with the program. Highlighting the one child whose lead level dropped dramatically makes a great story, but it ignores everyone who never enrolled, dropped out, or got worse. A population claim needs the whole population's rate, not its best anecdote. Evaluation is where population health earns the authority to ask for money, staff, and power, because rates are the only currency outsiders can actually check. Question 30. A teen pregnancy prevention program delivers health education in classrooms, operates a confidential clinic serving individual clients, and secures a school board policy that supports comprehensive health education. What does this combination demonstrate about implementation in population-focused practice? Your options are A. That implementation should occur at only one level at a time so that outcomes stay measurable. B. That systems level work replaces individual level work once a program matures. C. That interventions can be implemented at the individual, community, and systems levels at the same time to reach a population. D. That community level work is reserved for populations that have already developed disease. Which would you go with? Lock it in before the reveal. The correct answer is C. That interventions can be implemented at the individual, community, and systems levels at the same time to reach a population. C is correct because the three levels of practice focus are individual, community, and systems, and a single population goal can be pursued at all three at once. Classroom education targets the community level, the clinic reaches individuals, and the board policy changes the system that shapes both. Reaching an entire population usually requires working at more than one level because no single level touches everyone. A is wrong because restricting a program to one level narrows its reach for no methodological gain. Population outcomes are measured on population indicators regardless of how many levels the program operates at. B is wrong because the levels are complementary rather than sequential. Policy change makes individual services more available rather than making them unnecessary. D is wrong because community level work applies at every level of prevention, including primary prevention with entirely healthy groups. Nothing about it is limited to populations with established disease. One program can be individual, community, and system focused all at once. Public health nursing operates at three levels of practice focus, and recognizing this pattern is a core skill. Individual focused practice changes knowledge, attitudes, and behaviors of individuals and families. Community focused practice changes community norms and awareness. Systems focused practice changes organizations, policies, and laws. This is a separate axis from levels of prevention, which name timing relative to disease rather than the target. Each level alone has a predictable failure mode. Individual work evaporates when funding ends. Community work shifts norms without guaranteeing access to services. And systems work creates authority nobody on the ground was prepared to use. Working at all three levels compensates for each other's gaps. Trace the teen pregnancy program through this logic. Classroom education is community focused. The confidential clinic is individual focused. And the school board policy is systems focused, protecting the curriculum past a single grant cycle. Policymakers respond to demonstrated results, so systems change often comes last. A nurse who can teach but can't influence policy will watch good programs end on schedule, and the population returns to where it started. Question 31. A nurse is planning services for night shift nurses employed across 11 hospitals in 3 states. The members have never met one another and share no geographic boundary. What they share is a work schedule. Which term correctly describes this group? Your options are A. Community, B. Aggregate, C. Community of solution, D. Population. Don't overthink it. Which one feels right? The correct answer is D. Population. D is correct because a population is a collection of individuals who have one or more personal or environmental characteristics in common, and its members do not have to interact or share a place. Working the night shift is the shared characteristic, and that alone is enough. The explicit statement that members have never met is the exam's standard signal for this term. A is wrong because a community requires interaction among its members and usually a shared location. The STEM rules both out deliberately. B is wrong because an aggregate is a segment of a population narrowed until a nurse can interact with it directly. A group spread across 11 hospitals in 3 states is not directly reachable. C is wrong because a community of solution forms around a specific shared problem that crosses normal political boundaries, such as several towns sharing a watershed. Nothing here describes a problem that unites the group. Night shift nurses across 11 hospitals in 3 states have never met and never shared a city and never assembled in one room. Yet they are a legitimate target for public health work because they share something that matters, a schedule that carries real health consequences. A population is a collection of individuals sharing one or more characteristics. 2 absences complete the definition. Members don't need a shared geographic boundary, and they don't need to interact with one another. A shared trait alone is enough to belong. The standard examples all illustrate the same absences. Parents of school-aged children wherever they live. Night shift nurses across many hospitals, all adults over 65. Everyone with type 2 diabetes. In each case, members are scattered and unacquainted, and the shared characteristic does all the definitional work. 2 confusable neighbors sit on either side. A community adds interaction and usually place to a group of people. An aggregate subtracts scale, narrowing a population down to a group small enough to work with face to face. Population is the broadest and most abstract of the 3, and that abstraction is a feature, not a flaw. It lets public health name a problem at the scale it actually exists, rather than the scale at which someone happens to be standing. Question 32. From the larger group of all night shift nurses in a region, a researcher narrows her focus to the medical surgical night shift nurses at one specific hospital so that she can meet with them face to face. What is the narrowed group called? Your options are A. A population, B. An aggregate, C. A vulnerable population, D. A community of interest. Got a guess? Lock it in. The correct answer is B. An aggregate. B is correct because an aggregate is a selected segment of a population, small enough that the nurse can interact with it directly. The defining features are that it is a subset and that it is reachable, which is exactly what narrowing to 1 unit at one hospital accomplishes. This is the course's own illustration of the term. A is wrong because the population is the larger group she started from, meaning all night shift nurses in the region. Narrowing it produces something more specific than a population. C is wrong because a vulnerable population is one whose social, economic, environmental, or political position makes it more susceptible to health problems and less able to recover. Nothing indicates that these nurses face that kind of disadvantage. D is wrong because a community of interest is bound together by a shared identity or interest around which members actively interact. The STEM describes a work unit selected by a researcher, not a group organized around a shared bond. A population can be defined precisely and still be impossible to serve. All night shift nurses in a region or all pregnant adolescents in a state are real populations, but no one can gather them in a room. Nursing practice needs a smaller, workable unit that still belongs to that larger group. An aggregate is a selected segment of a population, small enough to interact with directly. 2 features define it, and both must hold. It is a subset drawn from a larger population, and it is reachable, meaning the nurse can actually meet, teach, assess, or serve its members in person. Building an aggregate is a narrowing operation. You start with a population defined by a shared characteristic, then add constraints, like one hospital instead of every hospital, until the group becomes concrete. Each constraint sacrifices generality but buys reachability, and that trade is deliberate. Picture population as the broader circle, defined only by a shared characteristic. Aggregate is a subset nested inside it, narrowed for reachability. Community is a different kind of thing entirely, defined by interaction and shared place rather than scale. Don't confuse aggregate with population or with target population. Aggregate describes structure, a reachable subset, while target population describes selection, the group a program chooses to serve. The same pregnant teens in one county can be both at once, an aggregate by structure and a target population once a program picks them. Question 33. Residents of a small rural county shop at the same 3 stores send their children to the same school and turn out together for the volunteer fire department fundraiser every spring. Which term best fits this group and on what basis? Your options are A. Community, because the members share characteristics and interact with one another. B. Population, because the members occupy the same geographic location. C. Aggregate, because the group is small enough for a nurse to work with directly. D. Target population, because the group could be selected to receive an intervention. Which one is it? Pause the video if you need more time. The correct answer is A. Community, because the members share characteristics and interact with one another. A is correct because a community is a group of people who share something in common and interact with one another, often within a shared place. Interaction is the ingredient that separates a community from a mere population, and the STEM supplies 3 separate examples of it. Shared institutions and civic life are the classic markers. B is wrong because shared geography alone does not make a population, and a population does not require geography at all. The mutual interaction described here points past the term population to community. C is wrong because an aggregate is a subset of a larger population narrowed to a workable size. A whole county's residents are being described as a group in their own right, not as a slice carved out of something larger. D is wrong because a target population is the specific group selected to receive an intervention. No intervention has been proposed, so nothing has been targeted. In everyday speech, community gets used for almost anything. The medical community, the online community, even car owners who share a brand. But in this material, the word has a precise meaning, and that precision is exactly what gets tested. A community is a group who share something in common and actually interact with one another. The key ingredients are shared characteristics, interaction, and usually proximity, but the word doing the real work here is interaction. A population only needs a shared characteristic. Its members can be total strangers scattered across a continent. A community requires relating to one another, which builds relationships, institutions, and shared expectations that an intervention can actually reach. That's a practical difference, not just a definitional one. A community can be reached through its pastor, its principal, or its union hall, while a population has no such channels at all. Shared stores, schools, events, and mutual support all point to community. Geographic dispersion or lack of interaction points toward population instead. Remember, a shared address is just the most common way connection happens. It's the connection itself that defines a community. Question 34. A school nurse reviews 2 groups at her middle school. The first is a 6th grade class of healthy students who get very little physical activity. The second is a group of students who already meet clinical criteria for obesity. Which labels apply? Your options are A. The first is a population at risk and the second is a population of interest. B. Both are vulnerable populations since both consist of children. C. The first is a population of interest and the second is a population at risk. D. The first is an aggregate and the second is a community. Take a second. Which answer would you pick? The correct answer is C. The first is a population of interest and the second is a population at risk. C is correct because a population of interest is an essentially healthy group that could improve factors promoting or protecting health, which fits inactive but healthy 6th graders precisely. A population at risk shares an identified risk factor or exposure that threatens health, and obesity is that identified factor. The line between the 2 terms is whether a defined risk factor is already present. A is wrong because this reverses the 2 definitions. Healthy with room to improve is a population of interest, while carrying a documented risk factor is a population at risk. B is wrong because vulnerability refers to social, economic, environmental, or political disadvantage that raises susceptibility and impairs recovery. Being a child does not by itself establish it, and neither group is described as disadvantaged in those ways. D is wrong because aggregate and community describe reachability and interaction rather than health status. Neither term captures the distinction the STEM is built around. Two classrooms in the same school need two different labels, and getting the label right decides what kind of program each group should receive. A population of interest is essentially healthy with room to improve, while a population at risk already carries an identified nameable risk factor. That single distinction determines whether a group needs primary prevention, like activity and nutrition education, or secondary prevention layered on top, like screening and early detection. Two more terms complete the set. Vulnerable population describes social, economic, or political disadvantage, not clinical status or age. Target population simply names whoever a program selects to receive it, which is about scope, not health. The whole system reduces to one branching question. Has a specific risk factor been identified yet? Answer no. And the group is a population of interest. Answer yes. And it becomes a population at risk, with vulnerability sitting on a completely separate axis. Interest and at-risk describe health status. Vulnerable describes social position. And target describes selection. Mixing them up mismatches the program, so the terminology is never just bookkeeping. Question 35. 4 towns draw their drinking water from the same watershed. When contamination is detected upstream, the towns form a joint task force to address it. Even though each town has its own separate municipal government, which type of community have they formed? Your options are A. Geopolitical community, B. Community of solution, C. Community of interest, D. Aggregate community. Before I reveal it, which one do you think is right? The correct answer is B. Community of solution. B is correct because a community of solution forms around a specific shared problem and frequently crosses normal geopolitical boundaries. The watershed example is the standard illustration because the boundary is drawn by the problem rather than by the map. Recognizing the type matters, since the intervention has to follow the problem's boundary rather than city limits. A is wrong because a geopolitical or territorial community is defined by geographic or political boundaries such as a city, county, or school district. Here the towns are deliberately reaching across those boundaries. C is wrong because a community of interest is defined by a shared identity, interest, or characteristic rather than a place, such as a faith community or a professional community. Water contamination is a problem, not an identity. D is wrong because aggregate community is not a recognized type. An aggregate is a reachable subset of a population, and combining the two words does not produce a real category. 4 towns share one watershed. When contamination shows up upstream, town lines mean nothing because water doesn't respect boundaries. So the towns form a joint task force, creating what the field calls a community of solution, a group defined by a problem rather than a place. 3 real types appear in this material. A geopolitical community is bounded by geography or politics, like a city or school district. A community of interest is bounded by a shared identity, like a faith group or profession. A community of solution is bounded by a shared problem. There is no such thing as an aggregate community. That word pairing sounds technical, but refers to nothing. The watershed is the classic case. Contamination doesn't stop at a town line, so the towns organize around the problem itself. The same pattern shows up with school districts tackling adolescent mental health, or counties coordinating an opioid response. The type changes the method. A geopolitical community is measured with census data and reached through local government. A community of interest is measured through its own networks and reached through its leaders, since its members scatter across many tracts. A community of solution is assessed by the problem's footprint and requires negotiating across different authorities. These types aren't exclusive. A rural county is geopolitical. Its farming families form a community of interest, and if it joins neighbors on groundwater protection, that coalition becomes a community of solution. Question 36. A public health nurse analyzes 3 years of surveillance data on a cluster of hepatitis A cases, identifies a shared food source, and uses her findings to design a targeted intervention. Which role is she filling? Your options are A. Case manager, B. Health planner, C. Case finder, D. Epidemiologist. What's your answer? Commit to one before I continue. The correct answer is D. Epidemiologist. D is correct because the epidemiologist role means analyzing health problems in populations, determining causes, and designing interventions based on the data. All three elements appear in the STEM in that order. Data in, cause identified, intervention designed is the signature of this role. A is wrong because a case manager helps clients make decisions about managing health services and coordinates their care across providers over time. No individual client's care is being coordinated here. B is wrong because a health planner develops and implements health services for at-risk populations, such as organizing an immunization clinic. Planning follows once the cause is known, but the analytic work described here is the epidemiologist's. C is wrong because a case finder conducts targeted outreach to identify individuals who need help and connects them to care. That is field outreach to people rather than analysis of population data. Most nursing roles are defined by what the nurse does to or for a person. This one is different. It is defined by what the nurse produces, an explanation of why a population is experiencing a health problem. The role means analyzing health problems in populations, determining causes, and designing interventions based on data. All three must appear in sequence. Analysis without a causal conclusion is just incomplete assessment, and a cause without a designed response stops short of the role. Picture a cluster of hepatitis A cases over several weeks. The nurse pulls surveillance data to confirm the count exceeds baseline, interviews cases about food exposure, finds a shared source, and designs a response combining supplier notification, worker vaccination, and public communication. This role is often confused with case finding, but the direction of work differs. A case finder does targeted outreach to find individuals who need care. The epidemiologist analyzes aggregate data to explain a pattern. Both can happen in one outbreak, but they produce different things. Remember, a role describes who the nurse is being, while an intervention describes what she is doing. When a question asks for a role, the analytic work of explaining a population's health problem belongs to the epidemiologist. Question 37. A nurse organizes and staffs a childhood immunization clinic in a low-income housing complex, arranging vaccine supply, volunteers, space, and appointment scheduling. Which role does this activity name? Your options are A. Referral agent, B. Advocate, C. Health planner, D. Counselor. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Health planner. C is correct because the health planner role is developing and implementing health services for at-risk populations, and organizing an immunization clinic is the course's own example of it. The signal is the building of a service where none existed, complete with logistics. Planning and standing up delivery capacity is the distinguishing activity. A is wrong because a referral agent maintains current knowledge of community services and connects clients to those existing resources. This nurse is creating the service, not routing people to one. B is wrong because an advocate speaks or acts on behalf of individuals or populations to obtain needed care, including legislative work. Advocacy might have secured the funding, but the activity described is program construction. D is wrong because a counselor helps clients cope with stressors, prevent crises, and adapt to health changes through a supportive relationship. No counseling relationship appears in the STEM. Nobody calls logistics clinical work, which is exactly why the health planner role gets undervalued. But a well-designed clinic that opens on the wrong day at the wrong hour in the wrong building will vaccinate almost nobody. Picture a nurse noticing low immunization coverage in a housing complex. She secures vaccine supply, recruits volunteers, negotiates a community room instead of asking families to travel, and publicizes in the languages residents actually speak. Planning decisions determine who actually shows up, where the service sits relative to transit, when it opens relative to work and school, what documentation is required, and whether staff are trusted by the population served. The health planner builds capacity rather than using it. A referral agent connects clients to services that already exist. A manager administers ongoing caseloads, and a group leader delivers through group process. None of them construct a new service. Every barrier a population faces was designed in by somebody. The health planner is the nurse positioned to design it back out. Question 38. A nurse testifies before a state legislative committee in support of a bill that would fund lead abatement in older rental housing across the state. Which role is she performing? Your options are A. Advocate, B. Educator, C. Manager, D. Case manager. Which would you go with? Lock it in before the reveal. The correct answer is A. Advocate. A is correct because the advocate role includes facilitating efforts to obtain needed healthcare and speaking or acting on behalf of individuals or populations, and legislative advocacy for population health is named explicitly. Testifying for a bill on behalf of tenants who cannot easily speak for themselves is that role in its purest form. It is also where the specialty's social justice commitment turns into concrete action. B is wrong because an educator promotes health action and facilitates behavior change through teaching. Persuading lawmakers to fund a program is not health teaching aimed at behavior change. C is wrong because a manager handles caseload demands involving multiple individuals and coordinates resources. Nothing in the STEM involves caseload or resource administration. D is wrong because a case manager integrates and coordinates services across providers for clients over time. Legislative testimony operates at the systems level rather than on any individual's care plan. Advocacy has an endpoint most descriptions leave out. It starts with pleading a cause on behalf of people who cannot fully advocate for themselves, but its ultimate aim is building their capacity to advocate for themselves. Advocacy that never transfers that capability creates permanent dependence dressed up as a good outcome. The advocate role means facilitating access to needed care and speaking or acting on behalf of individuals or populations, spanning legislative advocacy too. At the small n, a nurse calls a landlord about mold where a child with asthma lives. In the middle, a nurse redesigns intake so people without permanent addresses can enroll. At the large end, a nurse testifies before a legislative committee for tenants who will never know it happened. The role isn't optional for this specialty, and the reason is structural. Public health nursing serves vulnerable populations who are underserved precisely because they lack standing to secure resources through ordinary channels. Advocacy is a named standard of professional performance, not an admirable extra, and it's where social justice, equity, and population accountability converge. Three neighboring roles create predictable confusion. An educator teaches what people should know and do. A case manager coordinates existing services over time. A referral agent routes clients to resources that are already open. Advocacy appears specifically when something is being denied, missing, or unreachable. The standard framing treats advocacy as a communication skill, but the real distinguishing features are judgment and willingness to accept friction, choosing which fight to pick, accepting a partial win, and being willing to be unwelcome in a room. A nurse who only advocates when comfortable will only advocate for populations that already have friends. Question 39. A nurse maintains a current file of local food banks, rental assistance programs, and free dental clinics, and connects clients to the appropriate resource when a need surfaces during a visit. Which role does this describe? Your options are A. Case manager, B. Case finder, C. Advocate, D. Referral agent. Don't overthink it. Which one feels right? The correct answer is D. Referral agent. D is correct because the referral agent role means maintaining current knowledge of community services and connecting clients to those resources. Two elements define it, and the STEM supplies both: the up-to-date knowledge base and the act of linking. Keeping the file current is what makes the referral useful rather than aspirational. A is wrong because a case manager goes further, integrating and coordinating care across multiple providers over time and helping the client make decisions about managing services. A single connection to a resource stops short of ongoing coordination. B is wrong because a case finder conducts outreach to locate people who need help and are not yet in care. Here the clients are already present and their needs surface during a visit. C is wrong because an advocate speaks or acts on the client's behalf to obtain something being withheld or unavailable. Handing off to an existing resource that is open and accessible is referral rather than advocacy. Two nurses can both name a food bank, but only one knows it still has funding this week. That gap between stale knowledge and current knowledge is the entire substance of the referral agent role. The role has two elements, and the first is easy to skip: maintaining current knowledge of community services and connecting clients to those resources. That knowledge has to stay current because eligibility rules change, waiting lists grow, and funding cycles end. Connecting is the visible half, but it only works if the invisible half was actually done. Three roles sit close enough to confuse. A case finder does outreach to find people not yet in care before the person is present. A referral agent responds to a person already in front of them, connecting them to something that exists and is available. An advocate acts only when something is being denied or doesn't exist at all. The boundary tested most often is against case management. A case manager coordinates care across multiple providers over time, staying responsible for how the pieces fit. A referral agent makes a single, well-informed connection to a resource. The difference is duration and depth of ongoing responsibility. Food, housing, and utility assistance are social determinants of health delivered one household at a time. A nurse who connects a family to rental assistance may do more for that household's health than any clinical intervention that week, all from knowing something current and making a call. Question 40. Which pair of documents anchors the formal scope, standards, and competencies of public and community health nurse in practice? Your options are A. The Shattuck Report and the Lalonde Report, B. The American Nurses Association Scope and Standards of Practice for Public Health Nursing, and the Quad Council Coalition Core Competencies for Public Health Nurses, C. The Healthy People, National Objectives, and the 10 Essential Public Health Services, D. The Windsor Definition of Public Health and the Institute of Medicine Mission Statement. Got a guess? Lock it in. The correct answer is B. The American Nurses Association Scope and Standards of Practice for Public Health Nursing, and the Quad Council Coalition Core Competencies for Public Health Nurses. B is correct because the American Nurses Association document defines what public health nurses do and the standards to which they are held, splitting them into standards of practice that follow the nursing process at the population level and standards of professional performance covering ethics, education, leadership, collaboration, and advocacy. The Quad Council Coalition supplies the core competencies organized into domains such as analytic and assessment skills, policy development and program planning, communication, cultural competency, community dimensions of practice, public health sciences, financial planning and management, and leadership and systems thinking. Together they define the specialty's professional frame. AS is wrong because the Shattuck Report documented sanitary conditions in Massachusetts and the Lalonde Report introduced the health field concept. Both are historically important and neither governs nursing practice. C is wrong because Healthy People sets national health objectives and the 10 essential services organize the work of public health agencies. Neither defines nursing scope or standards. D is wrong because the Winslow definition and the Institute of Medicine mission statement define the field of public health itself. They frame the discipline rather than the nursing specialty's practice standards. A specialty that cannot state what it does and how well it must do it has no way to defend its scope, train its members, or hold anyone accountable. Public and community health nursing rests on 2 formal documents, and knowing what each contains is the real content here. The first document is Public Health Nursing, Scope and Standards of Practice. It splits professional expectations into 2 sets, Standards of Practice, which track the nursing process applied to populations, and Standards of Professional Performance covering ethics, education, evidence-based practice, communication, leadership, collaboration, and advocacy. The standards of practice mirror the same reasoning every nurse learns, with a population substituted for the individual at every step. Population assessment replaces the head-to-toe exam. Population diagnosis replaces individual nursing diagnosis. And rate comparison replaces asking whether one patient improved. The second document is the core competencies for public health nurses from the Quad Council Coalition. Its domains include analytic and assessment skills, policy and program planning, cultural competency, financial planning, public health sciences, and leadership and systems thinking, signaling that sustaining a program takes more than clinical skill. Together, these 2 documents, not Healthy People or the Essential Services, are what make public health nursing a recognized specialty rather than a job description, and why accountability to the population is a professional requirement rather than a personal preference. Question 41. A county commissioner argues that residents who develop lung disease after decades of smoking should bear the cost of their own care, since health outcomes follow personal choices. Which model of justice does that argument express, and how does it sit with public health? Your options are A. Social justice, which is the ethical orientation public health adopts. B. Distributive justice, which public health rejects in favor of market allocation. C. Market justice, which conflicts with the social justice orientation public health adopts. D. Non-maleficence, which obligates public health to avoid subsidizing risky behavior. Which one is it? Pause the video if you need more time. The correct answer is C. Market justice, which conflicts with the social justice orientation public health adopts. C is correct because market justice holds that health is an individual responsibility and that benefits are distributed according to what a person earns, deserves, or can purchase. Public health explicitly embraces the opposing model, treating health as a collective societal responsibility with all people entitled to a basic level of protection. The Commissioner's reasoning is coherent within market justice and directly at odds with the field-stated orientation. A is wrong because social justice is the view the Commissioner is arguing against. It would hold that society bears an obligation to assure the conditions for health, especially for those least able to secure them. B is wrong because distributive justice concerns the fair allocation of benefits and burdens and is part of public health's commitment rather than something it rejects. The option also mislabels the position being described. D is wrong because non-maleficence means avoiding harm and carries no implication about who pays for care. Using it to justify withholding care inverts the principle. A county commissioner argues that people who made unhealthy choices should bear the consequences alone. That view has a name, and public health explicitly rejects it in favor of its opposite. Market justice holds that health is an individual responsibility, and that benefits are distributed by what each person earns, deserves, or can purchase. Under this view, unhealthy behavior and inability to pay both produce outcomes that belong to the individual alone. Social justice holds the opposite. Society is obligated to assure the conditions for health, with particular attention to those least able to secure them alone. This contrast, articulated by Dan Beauchamp in 1976, still organizes public health's own self-understanding, visible in phrases like "for all people." The key nuance is that social justice doesn't deny behavior matters. It denies that behavior is freely chosen apart from conditions. A person can't buy produce that isn't sold nearby, can't walk where there are no sidewalks, and can't easily quit smoking when every circumstance reinforces it. Distributive justice, the fair allocation of benefits and burdens, belongs to the social justice commitment, not against it. And non-maleficence means avoiding harm, never an excuse to withhold care based on ability to pay. Question 42. A health department can place mobile mammography units in 4 of its 12 zip codes. It selects the 4 with the lowest screening rates and the fewest providers rather than rotating 1 unit day through every zip code. Which principle is guiding that decision? Your options are A. Health equity, because resources are allocated according to need in order to close an outcome gap. B. Health equality, because every resident of the county ultimately benefits from a stronger system. C. Market justice, because resources are following measurable demand. D. Non-maleficence, because uneven distribution prevents harm to the underserved. Take a second, and which answer would you pick? The correct answer is A. Health equity, because resources are allocated according to need in order to close an outcome gap. A is correct because equity means giving each group what it needs to reach its full health potential, which requires directing more support toward those facing greater barriers. Concentrating units where screening rates are lowest and provider supply is thinnest is that principle applied. Equity, not mere quality, is the stated goal of public health. B is wrong because equality would mean identical treatment for every zip code, which is precisely the option the department declined. Equal distribution can leave disadvantaged groups behind when their needs are greater. C is wrong because market justice distributes benefits by ability to pay or by demand. The department is deliberately overriding demand patterns to reach populations that have been underserved. D is wrong because non-maleficence is about avoiding harm from an intervention, such as stigma or displacement. Concentrating resources by need is an act of positive allocation rather than harm avoidance. 4 mammography units, 12 areas in need. Whether you spread those units evenly or concentrate them where need is greatest depends on a distinction. Ordinary speech usually blurs together. Health equality means giving every group the same resources. It's administratively simple and politically easy to defend. But identical inputs applied to unequal starting positions leave the neediest areas exactly as far behind as they started. Health equity means giving each group what it needs to reach its full health potential, which requires allocating more to those facing greater barriers. This is the actual goal of public health. And because it deliberately distributes unevenly, it creates friction that equality never does. Health disparities are the outcome gaps this all responds to. Differences in infant mortality, life expectancy, or diabetes control that are unjust and avoidable because they trace back to housing, income, education, and transportation. Closing them means acting on those root causes, not just adding a screening unit. When a scenario talks about tailoring resources to greatest need or closing an outcome gap, that's equity language. It looks unfair to those who receive less, but that's exactly why it's harder to defend, and why understanding the difference matters. Question 43. A nurse planning a diabetes education series for a Hmong community learns that many families consult a traditional healer and prepare foods that carry deep cultural meaning. Which approach reflects cultural competence? Your options are: A. Explain that traditional healing lacks scientific support and ask families to discontinue it. B. Build the teaching around the community's food traditions and coordinate with the traditional healer where possible. C. Deliver the standard curriculum unchanged since clinical content should not vary by group. D. Postpone the program until families agree to adopt a standard diabetic meal plan. Before I reveal it, which one do you think is right? The correct answer is B. Build the teaching around the community's food traditions and coordinate with the traditional healer where possible. B is correct because the culturally competent action incorporates and respects the population's beliefs and works within them rather than overriding them, adapting recipes rather than banning foods, and treating the traditional healer as a partner rather than an obstacle keeps the clinical goal intact while keeping the community engaged. Cultural humility adds the reminder that each community remains the expert on its own culture. A is wrong because telling families their healing traditions are worthless is cultural imposition. The failure mode cultural humility is meant to prevent. It also predicts poor attendance and lost trust. C is wrong because a curriculum delivered unchanged to every population ignores culture as a determinant of health behavior. The clinical content can stay accurate while the examples, foods, and messengers change. D is wrong because making adoption of an unfamiliar meal plan a precondition for service is coercive and delays care. It also assumes the standard plan is the only route to glycemic control. Before we get to the model, let's name the failure mode. Ethnocentrism means judging other cultures by your own standards, and cultural imposition is acting on that judgment by forcing your beliefs onto someone else. A nurse who dismisses a family's traditional healer thinks she's educating them. She's actually imposing her own standard, and the predictable result is that the family disengages from care entirely. A widely taught model breaks competence into 5 interlocking parts: cultural awareness, examining your own biases first, cultural knowledge, learning a population's health beliefs, cultural skill, the ability to assess cultural data, cultural encounters, direct engagement that corrects assumptions, and cultural desire, genuine motivation rather than checkbox compliance. Applied to a real plan, the difference is concrete. The competent design builds teaching around the family's traditional foods rather than replacing them, coordinates with the healer instead of contradicting him, and uses community members as educators, still aiming at the same clinical goal of glycemic control. Competence implies a finish line. Humility is a lifelong commitment to self-examination and treating the client as a true expert on their own culture. That's why humility is harder. It can't be checked off, only practiced. Question 44. A city documents that residents living in emergency shelters have much higher rates of tuberculosis, untreated diabetes, and hospital readmission, and that their circumstances make recovery harder once illness occurs. The health department then selects 3 specific shelters to receive a new on-site nursing service. Which terms correctly describe the group and the 3 shelters? Your options are A. The residents are a population of interest and the 3 shelters are a community. B. The residents are an aggregate and the 3 shelters are a population. C. The residents are a community of interest and the 3 shelters are a geopolitical community. D. The residents are a vulnerable population and the 3 shelters are the target population. What's your answer? Commit to one before I continue. The correct answer is D. The residents are a vulnerable population and the 3 shelters are the target population. D is correct because a vulnerable population is one whose social, economic, environmental, or political position makes it more susceptible to health problems and less able to recover from them. And people experiencing homelessness are the standard example. The target population is the specific group selected to receive an intervention, which is what the 3 chosen shelters become. The 2 terms answer different questions, one about susceptibility and one about program scope. A is wrong because a population of interest is essentially healthy with room to improve. This group already carries elevated disease rates and structural disadvantage, which places it well past that label. B is wrong because an aggregate is a reachable subset of a population, so calling the residents an aggregate and the shelters a population inverts the nesting relationship. The larger group cannot be the subset of its own slice. C is wrong because a community of interest is bound by shared identity around which members interact, and a geopolitical community is defined by political boundaries. Neither term captures susceptibility or program selection. Vulnerability has 2 halves and both must be present. A vulnerable population faces a social, economic, environmental, or political position that raises the odds of harm, and then blocks recovery once harm occurs. The first half raises the probability of harm. The second half deepens that harm once it arrives, because recovery requires resources like money, housing, transportation, insurance, paid time off, and social support that the very same disadvantaged position withholds. A wealthy executive and a man living in a shelter can carry the identical clinical risk for stroke, but the executive has rehabilitation, transportation, and paid leave waiting for him, while the man in the shelter has almost none of that recovery capacity. The risk is the same, the vulnerability is not. 4 terms ask 4 different questions. Population of interest and population at risk both ask about health status. Vulnerable population asks about social position. Target population asks a completely different question. Who was selected to receive the intervention? One group can carry more than one label at once. Calling a group vulnerable isn't a judgment on its members. It's a claim about the conditions surrounding them and an argument that those conditions create an obligation. That's the reasoning that turns an ethical commitment into a budget line. Question 45. During a measles outbreak, a health officer orders unvaccinated students who were exposed to remain out of school for the incubation period. Several families object that the order violates personal freedom. Which ethical reasoning supports the order? Your options are individual autonomy can be limited to protect the population's health when due process is followed, and the least restrictive means are used. B. Autonomy carries no standing in public health ethics, which recognizes only beneficence and justice. C. The order is justified because market justice permits agencies to withhold services from families who do not comply. D. The order is justified because non-maleficence requires agencies to eliminate every identifiable risk, regardless of the cost to liberty. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Individual autonomy can be limited to protect the population's health when due process is followed and the least restrictive means are used. Is correct because public health ethics keeps the classic principles but adds a population lens, and it routinely weighs individual liberty against collective protection. Immunization requirements, isolation, quarantine, restaurant closures, and reporting laws all constrain individual choice on that basis. The constraints are legitimate when justified by the common good, applied with due process, and kept to the least restrictive means that will work. B is wrong because autonomy remains a live principle in public health ethics and is what makes the least restrictive means requirement necessary. Discarding it would license unlimited coercion. C is wrong because market justice is not the ethical orientation of public health, and withholding services as punishment for non-compliance is neither the order's rationale nor a defensible one. D is wrong because eliminating all risk at any cost to liberty is not what non-maleficence requires. The principle asks agencies to weigh an intervention's unintended harms against its benefits, which implies proportionality rather than absolutism. Ordering exposed students to stay home really does limit personal freedom, and public health ethics doesn't hide from that. It constrains individual choice routinely and deliberately, then explains what justifies doing so. Public health keeps autonomy, beneficence, non-maleficence, and justice, but reframes each at population scale. Autonomy is balanced rather than absolute. Beneficence means designing programs for the population's benefit. Non-maleficence means weighing unintended harms, and justice means fairly distributing benefits and burdens. Two principles are especially prominent here. The common good recognizes shared achievements like clean water and herd immunity that benefit everyone, and stewardship means agencies must use public trust and resources wisely and transparently. Restricting liberty for the greatest health benefit is only justified when three conditions hold: a genuine population threat, due process giving the person recourse, and use of the least restrictive means. That is why one incubation period is defensible, but an indefinite exclusion would not be. Population ethics can't always resolve toward one person the way clinical ethics can, because interest conflict and someone has to decide. The mark of expertise is doing that, weighing transparently, proportionately, and with due process, not pretending the tension isn't there. Question 46. A nurse educator asks her class which historical figure is recognized as the first epidemiologist, and what work earned that recognition. Which pairing is correct? Your options are A. Lemuel Shattuck, who documented sanitary conditions in Massachusetts and recommended keeping vital records. B. Edwin Chadwick, who linked filth and poverty to disease and helped launch the sanitary reform movement. C. John Snow, who traced a London cholera outbreak to a contaminated water pump through systematic mapping and data collection. D. Florence Nightingale, who used statistics to demonstrate how environmental conditions affected soldier mortality. Which would you go with? Lock it in before the reveal. The correct answer is C. John Snow, who traced a London cholera outbreak to a contaminated water pump through systematic mapping and data collection. C is correct because John Snow is recognized as the first epidemiologist for his 1854 investigation of cholera in London, which he traced to the Broad Street pump by mapping cases and gathering data systematically. The work showed that disease could be linked to an environmental cause and controlled by removing it. This is the founding story of the discipline and one of the two history pairings most heavily tested. A is wrong because Shattuck authored the 1850 report on sanitary conditions in Massachusetts, whose recommendation shaped public health infrastructure. His contribution is infrastructure and surveillance policy rather than the founding of epidemiology. B is wrong because Chadwick's reporting on the sanitary conditions of the laboring population drove early public health legislation in England. He advanced sanitary reform without conducting the outbreak investigation that defines epidemiology's origin. D is wrong because Nightingale's statistical work on soldier mortality genuinely makes her a founder of data-driven public health. The specific title of first epidemiologist, however, is assigned to Snow for the cholera investigation. In 1854, a London physician named John Snow removed a pump handle, and in doing so gave birth to modern epidemiology. Snow plotted every death on a map, and the cases clustered tightly around the Broad Street pump, a nearby workhouse with its own well, and a brewery where workers drank beer instead of water, had almost no cases at all, pointing the blame squarely at the water. What makes Snow foundational isn't the answer he found, but how he found it: systematic mapping, careful counting, and chasing the exceptions that didn't fit his hypothesis. He showed that a disease could be traced to an environmental cause and stopped by removing it, without ever knowing the biological mechanism. Snow was part of a broader movement. Chadwick was the political reformer whose reporting on sanitary conditions launched public health legislation, while Shattuck was the architect who blueprinted infrastructure like vital records, disease surveillance, and immunization programs. Snow's map identified the pump, but it took a political argument to persuade the board to remove the handle. That combination of evidence and persuasion has defined public health success ever since. Question 47. Which figure is recognized as the first public health nurse in the United States, is credited with coining the term public health nurse, and established a settlement house and visiting nurse service that brought professional nursing into the homes of the poor? Your options are A. Mary Breckinridge, B. Lillian Wald, C. William Rathbone, D. Florence Nightingale. Don't overthink it, which one feels right? The correct answer is B. Lillian Wald. B is correct because Lillian Wald, working with Mary Brewster, founded the Henry Street Settlement and its visiting nurse service in New York City. She is recognized as the first public health nurse in the United States and is credited with coining the term itself. Delivering professional nursing to poor communities where they lived is the innovation that still defines the specialty. A is wrong because Mary Breckinridge founded the Frontier Nursing Service in rural Kentucky, bringing nurse, midwifery, and public health services to isolated Appalachian populations. Her contribution is rural access rather than the naming of the specialty. C is wrong because William Rathbone founded the first district nursing association in Liverpool, England, and worked with Nightingale on a model for nursing the sick poor at home. That work preceded and influenced Wald without occurring in the United States. D is wrong because Nightingale reformed military hospital conditions, championed sanitation, and separated sick nursing from health nursing. She laid intellectual groundwork for the field, but did not coin the term, or found American public health nursing. To understand why public health nursing looks the way it does today, we have to go back to a single settlement house in New York City, and to four names that keep getting confused with one another. Lillian Wald and Mary Brewster founded the Henry Street Settlement in New York, where Wald coined the term public health nurse. William Rathbone had already built the template in Liverpool, working with Florence Nightingale on district nursing for the sick poor. Mary Breckinridge later carried the idea into rural Appalachia. Keep these tied to their places and the exam traps mostly disappear. The radical idea was simple: send professional nursing into the tenements where poor families actually lived, instead of waiting for them to reach an institution they'd never enter. That same model, extended to horseback riders reaching isolated Appalachian farms, proved organized care could follow people anywhere. The National Organization for Public Health Nursing standardized the field in 1912. The Shepard-Towner Act brought federal funding for maternal and child health in 1921, before lapsing in 1929. The Social Security Act of 1935 then rebuilt and expanded the workforce during the Depression. Walt's nurses treated the household and neighborhood as their unit of concern, moving fluidly between bedside care and fighting for better housing and labor conditions. A public health nurse who gives care in the morning and testifies on housing policy in the afternoon isn't doing something extra. She's doing exactly what Henry Street defined the job to be. Question 48. A nursing history lecture covers 4 foundational figures. Which pairing of figure to signature contribution is accurate? Your options are: A. Mary Breckinridge founded the first District Nursing Association in Liverpool, England. B. William Rathbone established the Frontier Nursing Service in rural Kentucky. C. Edwin Chadwick distinguished sick nursing from health nursing and reformed military hospital conditions. D. Florence Nightingale distinguished sick nursing from health nursing and used statistics to link environmental conditions to mortality. Got a guess? Lock it in. The correct answer is D. Florence Nightingale distinguished sick nursing from health nursing and used statistics to link environmental conditions to mortality. D is correct because Nightingale separated sick nursing, meaning care of the ill, from health nursing, meaning the promotion of wellness and prevention of illness. And that distinction anticipates the whole logic of prevention. Her statistical demonstrations of how sanitation, air, water, nutrition, and rest affected soldier mortality make her a founder of data-driven population health as well as of nursing. Both halves of the pairing belong to her. A is wrong because the first District Nursing Association in Liverpool was Rathbone's work. Breckinridge founded the Frontier Nursing Service in Kentucky. B is wrong because this reverses the previous pairing. Rathbone worked in Liverpool, England, and Breckinridge worked in rural Appalachia. C is wrong because Chadwick was an English social reformer whose reporting linked filth and poverty to disease. The sick nursing and health nursing distinction and the military hospital reforms belong to Nightingale. Long before public health had its modern vocabulary, Florence Nightingale drew a distinction that still organizes the field today. She separated sick nursing, the care of people already ill, from health nursing, the promotion of wellness and prevention of illness. That distinction anticipates the entire logic of levels of prevention we use today. In the Crimean War, her real contribution was environmental and statistical. She attacked sanitation, ventilation, clean water, nutrition, and rest, then documented the drop in mortality with careful records and graphs that made the case impossible to ignore. She counted deaths by cause over time and presented comparisons that drove policy change, making her a founder of data-driven public health as much as of modern nursing. That pairing of statistics, sanitation reform, and a population-based approach is what gets tested, and it all belongs to her. Sick nursing responds to illness that already happened. Health nursing acts on the conditions that determine whether illness happens at all. Nightingale saw that 100 years before, the field built the epidemiology and statistics to prove it. Question 49. A community health nurse runs 3 activities in 1 week. A tuberculin skin testing day for shelter residents recently exposed to an active case, a bicycle helmet giveaway at an elementary school, and a cardiac rehabilitation exercise group for adults recovering from myocardial infarction. How should the 3 be classified? Your options are A. Secondary, primary, and tertiary prevention, in that order. B. Primary, secondary, and tertiary prevention, in that order. C. All 3 are primary prevention because all 3 prevent something. D. Secondary, and tertiary prevention, in that order. Which one is it? Pause the video if you need more time. The correct answer is A. Secondary, primary, and tertiary prevention, in that order. A is correct because skin testing is screening. And screening is always secondary prevention because it looks for disease early in people who still feel well. the helmet giveaway acts before any injury occurs, which makes it primary prevention through specific protection. Cardiac rehabilitation follows an established diagnosis and works to limit disability and prevent complications, which is tertiary by definition. B is wrong because this misclassifies screening as primary prevention, which is the single most common error in this content area. Testing exposed residents means looking for disease that may already be present. C is wrong because grouping everything under primary prevention ignores the timing that defines the levels. The levels are set by when the action occurs relative to disease, not by whether the word prevention applies. D is wrong because the helmet giveaway is not screening and nothing is being detected. It protects a healthy population before injury, which places it at the primary level. Levels of prevention aren't organized by severity, cost, or setting. They're organized by a single variable, timing relative to the disease process. Primary prevention acts before disease occurs, targeting healthy populations to keep them that way. Secondary prevention detects disease early through screening while it's still asymptomatic. Tertiary prevention acts after disease is established, limiting disability and restoring function. This model comes from Leavell and Clark, and it maps directly onto the natural history of disease, susceptibility, subclinical change, clinical illness, outcome. The three levels are simply 3 points of possible interruption along that one timeline. The most common error is calling screening primary just because the people feel healthy. But screening looks for disease that may already be present, so it's secondary. Immunization, by contrast, builds immunity against disease that isn't there yet. That's what makes it primary. Education shifts levels depending on who's being taught and why, and when a whole group is involved. One label is assigned based on the group's predominant status. Whenever you classify an intervention, ask one question: where does this action fall relative to the disease process? That answer, not how it feels, is what determines the level. Question 50. A county wants more residents walking regularly. Nurses teach families how to use a new trail. The county builds the trail to change the physical environment, and the city council allocates the construction funding. Which framework do these three actions illustrate? Your options are A. Primary, secondary, and tertiary prevention. B. Assessment, policy development, and assurance. C. Individual-focused, community-focused, and systems-focused practice. D. Community-based, community-oriented, and population-focused nursing. Take a second. Which answer would you pick? The correct answer is C. Individual-focused, community-focused, and systems-focused practice. C is correct because the three levels of practice focus describe the target of an intervention. Individual-focused practice changes the knowledge, attitudes, beliefs, and behavior of individuals and families, which is what teaching families to use the trail does. Community-focused practice changes community norms and the shared environment, which is the trail itself. And systems-focused practice changes organizations, policies, laws, and funding, which is the council's allocation. A is wrong because the levels of prevention classify when an action occurs relative to disease. All three actions here are primary prevention, so that framework cannot distinguish them. B is wrong because the core functions describe what a public health agency does across a whole problem, from finding out to deciding to delivering. Building and funding a trail is all downstream of assessment. D is wrong because the practice areas classify a nurse's mode of practice by who the client is. All three actions here serve the same county population, so that framework does not separate them either. Public health has 4 different frameworks that each happen to contain exactly 3 items, and that coincidence causes more mix-ups than any single concept in the course. A scenario describing 3 related actions could be asking about any of the 4. So the real skill is knowing what each framework actually tracks. Levels of practice focus name the target of change, individual, community, or systems. Levels of prevention name timing relative to disease, primary, secondary, or tertiary. Core functions name the system's job, assessment, policy development, or assurance. Practice areas name the client, community-based, community-oriented, or population-focused. Take a county building a walking trail. Teaching families to use it, building it, and funding it all look like three related actions, but they only separate along the practice focus framework. Since all three are primary prevention, all sit in policy development or assurance, and all serve the same county population. The habit that resolves the confusion is asking what the scenario is actually varying, not counting to three. If the actions differ in who is targeted, decide or timing or client, match that difference to its framework. These four frameworks are not competitors and they never collapse into one another. They are separate lenses that can all apply to the same activity at once. Fluency means holding all four labels on one action without letting any of them crowd out the rest. And that brings our question and answer session on Module 1, Foundations of Community and Public Health Nursing, to a close. To put these ideas into practice, visit our website using the link in the description below. There, you'll discover hundreds of free practice questions plus complete study guides, all ready for you to use. It's a great next step towards strengthening your understanding and building lasting confidence before exam day finally arrives. Hit subscribe to catch the next set of questions, and good luck on your community health exam.